Hello everyone, welcome to the residence online teaching program by Tamil Nadu and Pondicherry chapter of IRIA along with YUWA IRIA. Today, as we have already told, this is going to be the spotter marathon for almost an 8 hours of session that we have scheduled. It's going to be a pre-lunch and post-lunch session. So without much ado, I would like to welcome Dr. Anbarsu sir, who will be our opening batsman as usual. And he will start off with the approach to spotters and Oskis, and then discuss the first set of spotters. Over to you, Anbarsu sir.
Thank you, Murali Krishna. Another fantastic edition today. Let me go for sharing my desktop. Are you able to see the screen?
Yes, sir.
Okay, excellent. Right. Okay, good morning, everyone. And another marathon edition. It's actually marathon for you people, but for us, it's a bit of a relay. So the PG teaching is going to be done today. And again, it's sort of a TNPOI state IRA team has done a fantastic job this year. Highest number and duration of PG teaching in India for any state chapter. Consistently over the past month, again, Amarnath and Abu and their team, Murali Krishna, our technology lead, and the YUWA team, and of course all the office bearers, EC members, CC members, everybody cooperated with this program, and they have been fantastic this year. And thank you very much, everyone. Take this opportunity to thank you all. And on behalf of our state IRA, I would like to thank our teachers today. I think Dr. Chidambaranathan is known for his excellent spotters and particularly tough ones. Even consultants, we have a lot of difficulty in getting his spotters. And Dr. Vijay Bhaskar Noori is a fantastic gentleman from Hyderabad, excellent in chest and cardiac radiology. Dr. Varaprasad is our the top guy in MSK radiology, the secretary of the MSK Society, has been teaching MSK consistently for the past 4 weeks with us. Dr. Srinivas Dasai, famous radiologist from Mumbai, and Dr. Venkata Sai, our Professor Sai, our lead at the SRMC, and fantastic gentleman, and he is going to talk to you regarding some fantastic spotters today. Kushaljit Singh Sodhi is our pediatric man. He is also going to be the editor of our pediatric book from the IRA, again, a fantastic radiologist, a good teacher. So there's going to be some fantastic teachers from all over India who's going to teach you today, and it is an excellent opportunity for you to learn. So I know you people have got up in the morning a little bit late and not even having a shower, that's okay. And most of us might not have had breakfast. You probably have some biscuits and coffee and tea by the side of your laptop. Again, make sure you don't miss out on today's teaching. It's going to be a fantastic session. So just a little bit of recap on OSCE. OSCE is something which you shouldn't be worried, because if you are going to be in the university side, then it will be conducted by your own examiners, and therefore you will be fine with that. It's basically a standardized tool of examination. As you know, it's an objective. There is a proper objective to that exam. The scoring procedures are standardized. It's very structured. So everybody will get the same X-ray. Everybody will get the same spotters, and everybody will be asked the same questions, and the expected answer is also the same. And it is clinical. It's not only radiological, but can be clinical as well. So it's a clinical radiological thing. And of course, this is sort of widely accepted as a standardized tool all over the world. And this is from the Canadian exam content. So 3 things are sure. I'm not going to talk the same thing. 1, exams are nearer, very close. Okay. In the DNB exams, again, your examiners will be able to give you the transition. I'm sure they will be able to accommodate that you are the first batch probably going to take the DNB exams, and therefore they probably give you that transition period difficulty to you, so that you know it will become more probably tougher in the future. But now I'm sure it will be going to be very easier. So don't fumble on descriptions. This is something which happens in the exam, not only in the exam, but also sometimes if you ask a question, people confuses their descriptive words from ultrasound to CT to MR. in sometimes suddenly when you show an MR, they'll start with there is an hypoechoic lesion, and when it is a CT, hypodense lesion. And this is a mistake which is commonly done by non-radiologists. Okay, so as a radiologist, our description should be very, very sharp. And even when you are sleeping, if somebody show you an ultrasound, you have to first recognize it's an X-ray, it's an ultrasound, it's a CT, it's an MR. So you have to use the appropriate description. So description is something where we will not be able to be forgiven. So you have to be very, very careful. So use the appropriate word or descriptions, and that gives you a lot of confidence in the examiner side that you are good in your subject. So make sure that you get your descriptions right, and don't make gross errors. If you don't know, probably you can go for the differential diagnosis, discuss the differential diagnosis, but because you wanted to hit the ball to the 6, don't get caught on the boundary line. Okay, don't make gross errors, and help examiners. All the examiners coming to the exam actually to pass you, so that if you say the appropriate words and if you say the appropriate diagnosis, then it will be easy for them to pass you. So you have to help them a bit. So that's where all your 3-year preparation is going on now. So OSCE is about specific questions and specific answers. And so it can be anything. It can be about technique. What is the technique? How do you do it? What are the indications of this technique? What are the contraindications of this technique? It can be questions on radiological anatomy. What is the structure? Okay, what is the function of this particular nerve? Questions on pathology, of course. For example, if they show you a lesion in the chemo, for example, a carotid body tumor, they may ask you a question on what are the other locations of chemoreceptor cells, because that's important. So if you see one chemodectomas, then you should know where to look for other chemodectomas. And they can put a cassette and catheter and then ask you questions on that. And the questions should be ideally fixed, and the expected answers are also fixed by the examiner after discussion with the co-examiners prior to the exam. So it's actually a tough on the examiner side. It's actually boring for the examiner, because they cannot ask you questions beyond that particular discussion, and it should be sort of written in black and white, and they should have it, and then they should mark you on that particular area. So that deviation is not allowed in OSCE, and that is why it is actually a structured examination. So don't worry about OSCE. You will all be doing fine. Just think about the appropriate answers in that appropriate question. So first 3 of them we are going to discuss. There are going to be 20 spotters. All spotters are a little longer today, little tougher today. The first 3 will be on the OSCE type, and all the others will be on the spotter type. All right, so let's start on head and neck spine, and I would like to thank my fellow Dr. Ashwini for compiling this. So this is an ultrasound, and you can see where it has been done. It's written there. I want you to write 2 findings and 1 interpretation. All right, I want you to do this first before I put the next image. You cannot go back and recorrect this. What you're writing now is the final answer. So what are the 2 findings in this particular image? If you wanted to ask where is the scan is done, at what level, it's written there. Okay, it's written as right side floor of the mouth. So it is showing you an abnormality which is little brighter, and so you tell me your findings of that. Just a finding is like a description, and then another finding, and putting together you should give one interpretation. Okay, I'll wait for about 45 seconds to do that. Let me just switch on my timer. Okay, I'm going to move now. So you have written 2 findings for 1A, finding 1, finding 2, and 1 interpretation of these findings, and then 1B of the same question. Okay, this is a very specific question. The arrow mark, there's an arrowed area. In your report, what are the 3 points you will mention about the arrowed structure or area? 3 points you will give. I'm not asking you the diagnosis. It belongs to the same patient whom we saw earlier. I'm not asking you the diagnosis. I want to mention 3 important points you will mention about this structure. If you want to mention, you can mention the diagnosis. Doesn't matter. But what are the 3 additional points needed for the surgeon? About this structure. I'm not asking about anything else. It's about this structure. Simple questions, which one you will do normally otherwise as well. Okay, I'm just going to move on. 3 points you will mention about the arrowed area in your report, either in the conclusion or in the body, doesn't matter. It's not about the diagnosis, but about that particular area. What are the things we should mention? Okay, moving on. So here, this is an MR. There is an arrowed area. What is the location, anatomical location of the arrowed area? And tell us 2 differential diagnoses. Again, it has got 2 parts, so you have to write the answers accordingly. One is an axial image, one is a coronal image. Okay, next one. Okay, here I have given you 2 landmarks on this ultrasound. One is given as masseter, the other one is given as angle of mandible. The red is the question. Where is this lesion and what is the diagnosis? And the same red is mentioned at the lower half of the image, where you can actually see 2 different images are there. One is labeled as TR, that is transverse. The other one is vertical. So basically there is a transverse scan and a sagittal scan of the same lesion which has been done, and that is an important aspect which helps to make the diagnosis. So the landmark is given just to let you know where the anatomical location of this particular scan is done. So where is this lesion located and what is the likely diagnosis? It's only 2 specific answers. All right. Okay, moving on. Next is 17 are spotters. Okay, again, you will have 30 seconds for each spotter because they're all little long spotters. So this is the fourth spot. This thing is going to be a spotter. There are a combination of ultrasound images and MRI is there. So you just need to write the diagnosis. complete diagnosis. It's always a complete diagnosis. Okay, moving on. This is 5. Okay, just see if you can get the diagnosis based on these 2 images. If you're not sure, I will just try to focus you in the area there. It's again, you need to write the complete diagnosis. Okay, moving on. 6, diagnosis. Moving on. 7, what is the variant? Don't worry about nasal septum. That is something which is there with everyone. Moving on. 8, what's the diagnosis? Don't worry about the sinus. It's a question related to orbit. Moving on. Complete diagnosis. Moving on. 10. Moving on. 11. Twelve. 12. 'Moving on. 13. 14. 15. 16. 'I'm just leaving it for some time because this diagnosis is very important. Going to move on now. 17. The sequences are mentioned there, and then there's a T1, T2 at the top. $18. $19. There is a T2 post contrast T1, T2 and post contrast T1. Next one is the last one, and then we'll go for answers. Last one. So again, a complete diagnosis. Okay, excellent. You're all ready for answers. Let's go through the answers now. So the answers. So give marks to yourself. The OSCEs, each OSCEs will carry 3 marks each. That will be 9 marks. And the remaining 17 will carry 2 marks each, or 1 mark each, 17. So 17 plus 9 will be 28. All right. So the OSCE, the findings here on this first case, this is right side floor of the mouth. So floor of the mouth, if you see an echogenic area showing posterior acoustic shadowing, we are dealing with the calculus. Okay. There's no other structure, no other pathology which looks like that. You have the commonest thing would be a stone. On the right side floor of the mouth, it has to be a submandibular stone. So what stones will do? Stones will cause the dilatation of the duct. So on your right hand side, let me just get the pointer. I think felt tip pen works. Okay. Okay, so here is the dilatation of the duct, and here is the stone with the posterior acoustic shadowing. So 2 findings will be an echogenic area causing posterior acoustic shadowing, suggestive of a calculus or a stone, and then there is mild dilatation of the right submandibular salivary gland duct. That's all. These are the 2 main findings in OSCE. Okay, obviously this is a stone, so on the CT scan you will see a stone. Okay, but the question is not about the stone, but what are the 3 important points you will mention about the arrowed area. The arrowed area is actually the stone calculus, but you will be mentioning what? You will be mentioning the size. So when you're mentioning the size, you will be mentioning all 3 dimensions, AP, TR and craniocaudal. So all 3 dimensions should be mentioned, and this is applicable to any calculus. If you are going to see maybe a large bile duct calculus or renal or ureteric calculus, try and mention, particularly for Rogers calculi, all 3 dimensions. All the 3 are important for the surgeon. Second thing is the location. So the location here is that the distalmost submandibular duct may be just proximal to the opening. Okay, so that's important. It's anterior, so it's probably easily removable just by a nick on the floor of the mouth. The third one is the density. Okay, probably the location in this area, probably the density is not important, but if it is little deeper, then the density of stone, whether it is a renal stone or sometimes even a pancreatic stone or a salivary gland stone, it's important to mention the density. And the density should be measured in such a way that your ROI, region of interest circle, should be covering 2/3 of the lesion, 2/3 of the center of the lesion. So that gives you an reasonable, repeatable average ounce field unit or density of that particular lesion. So density, location, and the size in all three dimensions. These are the three things which is expected out of this. So location, size, and density. So this is the main thing which applicable to probably all calculi you will be reporting. Okay, so excellent. And then this is the what is the location of the arrow lesion, and this is the second case. So here we see a rounded, well-defined, slightly oval-shaped lesion located in the region of pinna. Okay, tragus. If you ideally say it's actually at the anterior margin of pinna, so it's actually the tragus. So a rounded lesion, well-defined lesion, is usually a cystic lesion in this location. It's a T2-weighted lesion. I didn't give you the T1. So this is a cystic lesion in the region of pinna. So the well-defined rounded cystic lesion in the region of pinna, asking you to give you the two differential diagnoses. You could mention about sebaceous cyst, epidermoid or epidermoid inclusion cyst. Even dermoid cyst has been reported in this area. First branchial cleft cyst can come here to reach this area. Pre-auricular sinus cyst can happen because of the sinus gets blocked and it can get collection. And boil or abscess or infection can occur in this area. So there are quite a few differentials which occur in this area. And there is a variant called antitragus or double tragus. So congenital variations can occur in this area as well, but they tend not to have a cystic configuration. So if you have a cystic lesion, and these are sort of some of the differential diagnoses you need to think about. Even if you mention any skin related cyst, if you mention is fine, but in this particular location, two classic locations are the first branchial cleft cyst or the pre-auricular sinus cyst are probably unique to this area. Okay, so the third question was about where is the lesion and what is the diagnosis. I given you the location of the masseter, location of the angle of mandible. So that means this will be in the region of cheek. So here this echogenic area which we are seeing is actually the parotid gland, and we can actually see the capsule of the parotid gland is sort of elevated. You can see that there. Okay, and so parotid gland, and this is the lesion which looks hypoechoic relative to the parotid. Okay, but if you look at this area, when the transverse dimension, you can see some linear echogenic septation like area there, which remains parallel to the probe even if you change the probe into vertical direction. That's the classic appearance of a lipoma. Lipomatous septations can have this appearance of parallel presentations in any plane which you are going to scan, and that is actually applicable to any lipoma anywhere in the body. And we all know lipomas can be echogenic, hyperechoic, or even mixed echoic. And and this is a CT scan which shows that intraparotid lipoma within the capsule. You can see the capsule continuing posteriorly on the CT scan, and you can see there is fatty infiltration of the parotid gland. So this is an intraparotid lipoma. Even if you mention cheek wall lipoma, it's acceptable. So where is the lesion? It's sort of juxtaparotid, paraparotid, or cheek region is reasonably acceptable, but the diagnosis is a lipoma. There's no change in that. All right. Okay, spotters, let's go on. So this is a papillary carcinoma thyroid lobe with nodal metastasis. So how do you know it's papillary carcinoma? First, you see the ultrasound here. You see multiple echogenic spots, which means it is microcalcification. And you see a large cystic component. It's taller than wide in shape. So it has got a classic TIRADS 4B type, and you can see a lot of internodular vascularity. And then there is internal jugular vein and carotid artery are in between with the right-sided enlarged node, which is having similar configuration. Solid nodules, calcification, cystic changes. You can see small microcalcifications. MRI shows the same finding. Solid cystic mass lesion in the right thyroid lobe with a metastatic node at the right level 3, level 4 region having the same appearance. This is a classic papillary carcinoma of the thyroid with nodal metastasis. It can come in CT, it can come in ultrasound, it can come in MR, but the diagnosis do not change. Right. 5 is, I asked you to concentrate on this area. The patient who presented with trauma, and if you look carefully, the vertebral artery on the left side, you can see the flow wide, but on the right side, you can see a high signal. Maybe there is a little flap there. So this is a right vertebral artery dissection. So the complete diagnosis will be a right vertebral artery dissection is something which you should mention. So right vertebral artery is your anatomy and dissection is your pathological diagnosis. 6 is diastomatomelia, obvious diagnosis. I'm sure most of you has got it. You got a 2 split spinal cord means diastomatomelia, whether it is with the 2 separate spinal meningeal tubes or not. I haven't shown you all the images. I haven't shown you the septation or a bony bar going between. But as long as you mention diastomatomelia or spinal dystrophism, it's an acceptable answer. Variant, this is paradoxical curvature of both middle turbinates, and the turbinates, if you look at the inferior turbinate, they actually curve in such a way the end is facing laterally, okay, but here the end is facing medially, so it's a paradoxical curvature of the middle turbinates. It's bilateral, so bilateral or paradoxical curvature of both middle turbinates. 8 is again a easy diagnosis, thickening of the right lateral rectus muscle, and thickening extends to the insertion site. And if you see this appearance, then this is an orbital pseudotumor or orbital inflammatory disease or idiopathic orbital inflammatory disease affecting the muscle. So this is a retention cyst, probably not significant. That's why I concentrate on the main pathology, and this sometimes can be a distractor in spots. 9 again asked for a complete diagnosis, given you an abnormal T1 low signal infiltrative lesions. This is a T1 weighted image. You can see multiple low signal areas. When you see multiple low signal infiltrative type of ill-defined lesions, you always think about metastasis. On the T1 weighted image, many of these remain as low signal areas. You can see that there, and you can see that here on the D12, and you can also see it here on the sacral regions. And here in the axial pelvis image, you can see a lesion which is at the bladder base, infiltrating the bladder base. This is a prostate malignancy. If you look carefully, you can actually appreciate a right obturator or external iliac node on the right side. And there is also sclerotic low signal changes affecting the acetabulum. So all these features are consistent with prostatic malignancy with sclerotic metastasis. If you mention nodal metastasis, if you picked up that, that's also good. And so it's a sclerotic spinal metastasis or skeletal metastasis from prostatic malignancy is your complete diagnosis. So metastasis alone will give you half a mark, but there is a purpose given for this. So I have reduced the number of spots, but it needs a lot of, putting everything together will be your test today. And you can see the bladder base elevation on the sagittal images. So always, whenever you see spinal metastasis in a male patient, automatically your eyes should shift to the prostate and see what's happening there. So number 10 is again an easy diagnosis, because on the T1 weighted image on your left hand side, you see a high signal linear structure related to a low lying spinal cord. So this is an intraspinal lipoma. You can see there is actually a posterior element defect at L4 and L5 level, and you can see the spinal, the phylum terminal is tethered to that area. So this is basically occult spinal dystrophism, because there is no skin defect, but there is an intraspinal lipoma, low-lying spinal cord, tethering of the final terminal, spinal dystrophism, and you can see the contiguity of the gap with the subcutaneous fat. And there is a arguable that there may be some neural elements within this tissue as well as going into the subcutaneous fat. As long as you mention spinal developmental spinal anomaly with an intraspinal lipoma, you will get the marks. Okay, this is an easy diagnosis. In X-ray, you see this paraspinal bilateral swelling. On the CT, you can see destructions and erosions of the vertebra, classic prevertebral and paravertebral abscess, and MRI shows the same findings. So basically, this is a TB spine with large paravertebral and prevertebral abscess. Okay, I don't think this will always come in every exam, not only in MD or DNB, it will come in its variations anywhere along the spine, even in FRCR exams and other board exams, because TB is now the favorite of the examiners, and it's been a favorite for our examiners for a long time. And 12 is a slightly tougher diagnosis. If you have mentioned right vocal cord tumor, acceptable, okay, reasonable differential diagnosis. But what we are seeing here is the features of vocal cord palsy. What do you see here? The right area epiglottic fold is deviated medially. You can see that there. And you can see the right vocal cord is larger, and there is medial deviation of the right vocal cord. So three signs here: medial deviation of right vocal cord, deviation of the area epiglottic fold, dilatation of the right piriform sinus, And if you ask my fellow, she will tell you 8 signs in total, 6 in on imaging and 2 on clinical. So I'm sort of learning from her now. So here is the signs of vocal cord palsy, which you need to pick up in any patients with hoarseness of voice. So if the lesion can be within the larynx, yes, it is possible. There is a possibility of a vocal cord tumor which may be infiltrating, and that may be the reason for this appearance. But however, it's very important that you look through the entire course of the vagus nerve and recurrent laryngeal nerve on the right side to ensure that we are not missing a lesion either at skull base level or within the brainstem, or along the right carotid space or right tracheoesophageal groove, or at the right subclavian artery margins where the right vocal cord takes off. So it's important to pick up a vocal cord palsy signs and make sure you chase everything. And in terms of left vocal cord palsy, obviously you will look at the chest. Okay, this is an interesting case where you will see on the plain CT 2 nodular lesions which are located in the expected location of thyroid, and it shows prominent enhancement consistent with the location, and appearances are consistent with the bilateral parathyroid adenomas. And you can see that there it is showing a bit of a washout on the venous phase scans. Um, and and obviously when you see such cases, your scan should include the chest and make sure we are not missing an enhancing lesion in the chest. But this is like, as long as you mention bilateral parathyroid adenomas on either side showing prominent enhancement behind the thyroid is the diagnosis. This is cervical TB lymphadenopathy, because we can see the necrotic nodes here at the lower neck, at the suprasternal region, and you can see the abscess, and the abscess is trying to come out. So this is a classic cold abscess becoming a cholesterol abscess trying to reach the skin. So this is when you see this type of appearances of abscess coming towards the skin, and you see a deep-seated larger subterranean lesion, then we are dealing with commonly a cold abscess. You can see the rim enhancing lesions. And classically it will be a tuberculosis. And this is an orbital hemangioma, again a classic appearance, well-defined appearance at extracornal space, and you can see sometimes there is notching and remodeling of the supraorbital roof, which is happening in this case, and following contrast homogeneous enhancement. And this is an orbital hemangioma. This case is important because patient presented with some sort of an ear discharge, probably about within the last month in our center. And you can see here bilateral mastoiditis type of appearance, fluid signal in both mastoids and middle ear. But when we scan, we found out this abnormal enhancing lesions, which is heterogeneous appearance in the nasopharynx. So whenever you see bilateral or unilateral mastoid effusions, particularly in adult patient, you need to think about nasopharyngeal mass lesion. Following contrast, you can see the enhancement, you can see the infiltration into the skull base. Both base occiput on either side are infiltrated. The clivus is also infiltrated. It's a classic nasopharyngeal carcinoma, obstructing the eustachian tube and presenting as mastoid effusions. Okay, so look out for that. So in your diagnosis, you should mention about nasopharyngeal mass, nasopharyngeal malignancy with bilateral mastoid middle ear effusion of fluid. As long as you mention, or at least think about the nasopharyngeal mass is the most important thing here. Okay, this is again an easy case. There is an intraspinal lesion which looks cystic on the T1 and high signal on T2. Following contrast, there is enhancement. So this was actually a differential diagnosis, include various, but probably one of the common ones would be an ependymoma. Okay, you can mention all the other glial tumors, fair enough, but this is an ependymoma. You can see associated cord edema here proximally as well as distally.
Anversus sir will join now. I think he's going to reconnect. Just hold on. Anversus sir will join now. I think he's going to reconnect. Just hold on. சார் நெட்டு போச்சா? இல்லையே, எங்களுக்கு எதுவுமே வரலையே. 18th நினைக்கிறேன். ஆமா, நீங்க எங்க ரூம்ல இருந்தே போயிட்டீங்களே. ஓகே ஓகே ஓகேங்க சார்.
17
இல்ல, நீங்க லாக் அவுட் பண்ணிட்டு லாகின் பண்ணோம். நீங்க ரூம்லயே இல்ல.
Okay.
17.
Which one you want me to start on?
17 sir, 17.
17. Okay, sure. Okay. 17, sorry about that. The net is not under our control. It's gone and come back. So this I was talking about this low signal T1 lesion and high signal T2 showing enhancement. This was actually an ependymoma. 18 is I was talking about this particular patient. This is actually arachnoiditis. You see, look for the signs of previous surgery. There has been a previous surgery. Can you hear me, Murali Krishna?
Yes sir,
okay?
yes sir. All good, all good. Yes.
Okay. All right. Okay. So here you can see the defect in laminectomy defect at the posterior element, and you can see the defect again. And you can see there is adherence of the spinal nerve roots, cauda sort of splayed and displayed and adherent to the areas of the periphery of the spinal canal. And this is a classic appearance of arachnoiditis. If you give contrast, it can enhance. So-called empty sac sign. Okay, 19 is again a lesion which is a T2 low signal here within the spinal canal and showing enhancement following contrast. And this was a meningioma. A differential diagnosis will be a neurogenic tumor. If you're able to connect it to a nerve root or going towards a neural foramen, then the diagnosis of neurofibroma will be first. But in this case, it's a very well-defined appearance, a T2 low signal, uniform enhancement, and this was pathologically proven meningioma. Intraspinal meningioma. Last case, here there are multiple low signal areas you can see here in the T1 weighted image within the vertebral bodies, and you can see wedge compression of 2 or 3 vertebral bodies here. In spite of wedge compression, you can still see abnormal low signal areas. If you actually transfer this to a plain X-ray, you will be able to make the diagnosis. This is like a multiple myeloma. So multiple myeloma is one of the malignancies where you will see the intact fatty marrow, while in metastasis, particularly when there is a disseminated metastasis, there will not be much fat within it. Okay, so that's my last case. I have, I think, a couple of minutes. Just so spotters can be confusing at times, head and neck, particularly head and neck and spine spotters. The appearances of the same pathology can show many variations, and that's where you should be very careful. But stick to the basics, stick to the anatomy, and use the common differential diagnosis. You will be right 90% of the time, and getting a 90% mark is good enough to pass the exam. Thank you very much for listening, and best wishes for the examiners. I will just see if I can see able to give you some doubts here, looking at the chat box. 18, I have done 9 and 10 answers. Somebody asked about 9 and 10 answers. Quickly again.
So probably you can run the answers, all the answers once, just the answers quickly.
Again, quickly?
Yes,
Right.
only the answer.
Okay, fine. Let me, yeah, okay. Okay, so the first one is a right submandibular duct stone with a dilated duct. That's the first findings. There is a submandibular duct calculus. You have to mention about location, size, and density. There is the location is at the tragus or auricle or pinna. The differential diagnosis of a tragus cystic lesion is sebaceous cyst, epidermoid inclusion cyst, dermoid cyst, first branchial cleft cyst, preauricular sinus cyst, or a boil or an abscess, or your differential diagnosis. 3 is an intraspinal lipoma.
Sir,
4th is
we need to see.
Tell me.
PowerPoint is not.
Oh, PowerPoint is not there, is it? Okay. I thought it is shared. Okay, it's not. Able to see now?
Yes, sir. Yes, sir.
Okay. So third one, sorry, fourth one is the papillary carcinoma of the thyroid with metastasis, and fifth one is the right vertebral artery dissection, and diastematomyelia, which is the sixth one. Seventh is the paradoxical curvature of both middle turbinates. Orbital pseudotumor 8. 9 is spinal sclerotic metastasis from prostate CA. 10 is occult spinous dystrophism with intraspinal lipoma. 11 is TB spine with large pre and paravertebral abscess. 12 is vocal cord palsy. If you mention right vocal cord tumor, you will get half a mark. 13 is bilateral parathyroid adenomas. 14 is cervical TB lymphadenopathy with cold abscess and cholesterol abscess. Abscess is fine. Orbital hemangioma. 16 is mastoiditis or mastoid fluid, middle ear fluid with a nasopharyngeal mass or nasopharyngeal malignancy, nasopharyngeal carcinoma in this case. 17 is a spinal ependymoma. 18 is arachnoiditis, and 19 is an intraspinal meningioma, and 20 is a myeloma. I'm just trying to go through the answer. Somebody was asking me differentiating meningioma and schwannoma in spine. It is there in books, but basically, if you're able to connect it to a nerve root, and then it is a schwannoma. If you're able to connect it to a neural foramen, it's a schwannoma. If you're able to see a dural tail sign, more in favor of meningioma, female more in favor of meningioma. So these are the differentiating features. And what else? 19 can be myxopapillary ependymoma. No, the age group is slightly different. This is a female patient. A myxopapillary ependymoma can look like this, but you can see, we are able to see the nerve roots are displaced a little posterior. In the myxopapillary ependymoma, it will be like an infiltrative lesion, something which is completely encasing the root. It is a slow growing, it's a more younger patient. And age is not given. Yes, you could potentially say that as a differential diagnosis, accept that. Nasopharyngeal CS, but optic nerves are normal. Right, I haven't seen the optic nerve. Probably normal, I guess. It's okay. Optic nerves are practically not included very well. Whatever you are seeing in one image, don't worry about it. Please explain arachnoiditis. It's arachnoiditis, basically an inflammation of the arachnoid, which the sign to see is it sort of it causes adherence of the cauda equina nerve roots. It displaces and distorts. So the orientation of the nerve roots is actually changed, as discussed. Vocal cord palsy signs, please. Medial deviation of the area epiglottic fold, enlargement of ipsilateral pyriform fossa, medial deviation of vocal cord, sometimes enlargement of the ipsilateral laryngeal ventricle. These are the signs. 19 melanoma. 19. Somebody asked 2 minutes. 19. 19 is not a melanoma. It's an intraspinal lesion. Why you want to think about melanoma? Why not TB? Which one? What is it? bladder CA or instead of prostate CA. The prostate CA is more common. It causes more likely sclerotic metastasis. Scheuermann's disease, 18B. Scheuermann's. No. This looks like an old age patient who had surgery. So don't think about Scheuermann's now. 16 can be extensive skull-base osteomyelitis. The nasopharyngeal mass is the key. Skull-base osteomyelitis has to have some reason, but it is infiltrating the central part of the skull base with a large nasopharyngeal mass, enhancing lesions. There is not much of a collection, more of a solid mass. So this is not skull-base osteoma. You have to think about malignancy. And why not TB? TB can be anything, but when you have bilateral mastoid fluid and there is an nasopharyngeal lesion, first think about malignancy rather than TB. 20 can be a hemangioma. The 20 is a multiple myeloma, multiple low signal lesions in old age patient. Where are the other doubts? Can you explain the last spotter, which is myeloma? So this will be my last doubt. See, basically here, what you see here is in an X-ray, you will see multiple small punched out osteolytic lesions. Exactly what you see on this particular image. You see multiple small low signal areas. The beauty of myeloma is it doesn't take away the entire fatty marrow completely, but you see a lot of collapse. So it can be osteoporotic. Okay, vertebral collapse. It can be metastatic. It can be myeloma. It can be lymphoma. But here there is osteoporosis can be a presentation of a myeloma. But here what you see is the multiple low signal areas with the typical appearance of a myeloma. Even if you on X-ray, it will be the same diagnosis. So this is one pitfall when you are diagnosing in a osteoporotic spine, and the myeloma can be overlapping. So you need to be aware of that. Metastasis is usually larger. Multiple small lesions are usually myelomas. Okay, I think that should be fine. We are good on time. I think we will close it. And thank you very much, and all the best, residents. And I think we have got now Dr. Chidambaranathan is online. Hello, Dr. Chidambaram. Right.
So you have to
Thank you
switch
very
on your
much.
audio.
You take over. I will close my audio.
Okay,
yes, I have finished.
We can hear you, sir.
Thank you very much. You have put actually good platform. Okay, we can proceed. Can I share that? This
yes,
one
sir.
is okay?
Please share your screen, sir. We now have next Dr. Chidambaranathan. Sir is the professor and lead consultant at Apollo Hospitals.
But can you see this one? Can you see?
Sir. No, sir.
No.
Go to the share slide, sir. Turn screen share on.
Okay.
Yes.
Now
we are able to see, sir. Now do your PowerPoint. Yes.
Okay. Yes. Can you see?
Yes, sir. Go for a slideshow, sir.
It's okay?
Yes, sir. Perfect. Yes.
Oh, can I start?
You can start, sir.
Okay, thank you.
Welcome, sir.
Thank you. This is indeed a great pleasure, Murli. It is sharing my experience to all of you. Indeed, actually, this is a great pleasure to participating in this program. Okay, so all of you know this spot is very important aspect. We'll go through quickly. As Anbarasu pointed out, it is important to know that OSCE type of module also. So today I have 3 modules. Okay, the one module is the first module will be you all of you know familiar with Vijay TV. This Adu, Idu, Yedu. Okay, the program. Okay, would have seen similar patient. Okay, most of the disease have the mimic similar. Okay, so clinical imaging feature to help distinguish always. That is our responsibility. So here this I show about 5 cases. The 5 cases contain each one having A and B. Okay, so they'll be each carry 2 marks. So totally 4 marks. So 5 into 20. So that's 5 4s are 20. So there'll be 20 marks here. We'll start with them. Okay, this is a really straightforward cases. Okay, maybe you can say A and B will be there simultaneously. I'll go through that, will be easier for you. So this is a case 1. This is 1A and 1B. So looks similar, but you go through carefully. Okay, the time start now. Maybe quickly we'll finish that first round of okay, then I'll share the experience of what are the cases I'll show. Okay, so there are some more images also. I'll show this one. This is a coronal image. You can say the coronal bone window, and this is a soft tissue window. This is A different case, B different case. Okay, so this is a coronal, and again will be coronal soft tissue window. You have to make only diagnosis, only one diagnosis. A, what is diagnosis? B, what is diagnosis? That's all. Okay, but there are some findings there. So there are axial sections. You can see some finding. So look similar, but there are subtle finding. Okay. Okay, that's all. Very good, very nice. You have written. Just put yourself a mark also. So we'll move on to the case number 2. The case number 2, here A and B. The two different cases. This is 8 years old, short stature, and having some abnormalities in the areas. Okay. So you can see here very carefully. Okay, this is a contrast, sagittal and coronal image. Similarly, another case, 6 years old female, impaired vision. This also sagittal and as well as coronal images. Just some more images I'll show quickly. This is a second A case. You can see that much more plain and as well as contrast. So I'll show more spectrum of cases. Don't worry, you will get full range, both axial and both coronal and sagittal. This is 2A. I think you can see. Okay. See, sometimes it will be important thing. No, history is important. Okay. So you always go through the history and make a diagnosis. And 2A. Let us go to 2B. This is again plane. This is a plane. This is a contrast coronal. Contrast coronal. So if you want to see the same thing in the sagittal, okay, I'll show. If you want, you can put a pointer. 12 time. Okay. So this is a lesions. Okay, here you can say this is coronal and plane. Okay, go through. So we'll move on to the next slide. Next case. Again, it will be 3A. This is 55 years old male, headache. There is a lesion in the posterior fossa. This is a T1 image, and this is post contrast and T2 image, and the GR images, and this diffusion. See, look at the diffusion and then ADC, and as well as T2 image. Go through, then make a diagnosis. Almost similar, but this is 50 years old male, and lesion is the posterior fossa, T2 image, GR images, and T1 image. And there is ADC and diffusion image. And there is contrast. Okay. I think okay. We'll move on to the case number 4. This lesion in the left temporal lobe. So this is 39 years old female, seizure. This is 47 years female with seizure, is fell down the bathroom. Okay. 4A and B. We'll go slightly more number of cases, more number of limbs. Say this is a T2 image and flare images, and you can see that GR images. So what is the diagnosis here? Then 4B, this is a T1 image, T2 image, post contrast, and this post contrast, diffusion, and ADC. Okay, like that. Okay. Now case number 5. This is 18 years old, had a head injury. Okay, there is some abnormality here. The orbit, I think he also mentioned about the orbit. We also put it. So this case number B, similar, but this is 19-month-old boy with there is wide eye reflex. Okay, there is abnormality in CT. What is abnormality? What is the diagnosis? I think no. Okay, now the module first one over, the similar one. The module second one is important to know. Okay, these are more of OSCE modules. As Anbarasu pointed out, we are going question. There's a questionnaire will be there. There is a mark also. Here 5 cases, each one have A and B, like similar case. but each carry 8 marks because each questions will be 4 marks. Okay, and there is a 5 cases, totally 40 marks. Now we'll move on to that. Both are gliomas. Case number 6A, both are glioma, but 6B also glioma. But the question here, what is the radiological sign as the imaging biomarker for mutation in these glial tumors? This is 4 marks. And name the genotypic case A and B. What is it? 6A, what is the genotype? And what is the 6B? What is it? There is important radiological sign. If you know the sign, then you can make a proper diagnosis of genotype also. Because it is a mandate. Now we have to show that we have to give the genotype also. Okay, because it carries the prognostic value. Okay, A and B, there is important sign to differentiate. So 6A and 6B. Okay, we have seen. Seventh is actually the 6 years old male with a seizure, and some of the images here. Here the question is a T2 image, coronal T2 flare images, axial T2, and there's a coronal T2. What is the imaging finding? Can you mention any one of the sign here? And what is the diagnosis? How do you confirm? Okay, so 2 marks for each. What is the imaging finding? Can you mention any sign, any particular sign here to make a diagnosis? What is the diagnosis? How do you confirm? That each question having two answer, 2 question and 2 answer. Okay, clear? And 7A, 7B, 24 years old seizure. Here the question, this will be axial T2, axial T2, axial T2, and this is a coronal flare. What is the single void area due to here? There are some single void areas. The images, see where is the single void areas. What is the diagnosis? What will be will be there any leptomeningeal enhancement in both cases, both 7B and as well as 7A. 7A also I'll show here. Okay. And the question is exactly, is there any leptomeningeal enhancement, both A and B? If you give, why? Maybe you can go through images again. There are imaging finding here and as well as here. Okay, there are abnormality here also. Okay, so this carry that one for the single void, and what is the diagnosis? 1, and the leptomeningeal enhancement 2 marks. 2 marks. Okay, so totally about 5 marks. Okay, so 8 marks totally. So here case number 8, 16 years old female, present with altered behavior, particularly no fever. So there is abnormality, and this is a T2 image, flare, and coronal T2 and coronal T2. What is the most likely diagnosis? What is the pathological process causing signal alteration in this case? What are the signal alteration? Why? There is some specific areas involvement. What pathological process causing this signal alteration? What are the confirmatory tests? Okay, this is important. Okay, then we will move on to the case number 8B. Also almost similar. The here question, what is most likely diagnosis? Okay, what is the pathological process causing signal alteration? The 2 questions. This is coronal T2. This is flare images, and there are some more images in the flare images, and this is a contrast flare images, coronal flare images. And here again, what is the pathological process causing signal alteration? Here also the involvement of lesion in the particular areas. Okay, so case number 9. What is the diagnosis here? Very simple case. What is the obvious diagnosis? So what is the pathological process involved? Okay, there is abnormality you can see, and T2 also. What's what is the pathological process involved. The diagnosis may be simple, but pathological process you have to mention about. Okay, now case number 9B. This is a T1 image, this is a T2 image, and this post contrast. Here, important thing, T1 image you can see observed nicely here, and there are abnormality. Here, that question is what is the diagnosis, and see the axial images, and what is the pathological process. Patient having progressive weakness both lower limb. There are some abnormality. Okay. Now, 10A. At another case, a progressive weakness lower limb 3 months. So here this is a T2 image, post contrast T1, and this is a T2 image. Okay, what is the diagnosis? You can see the axial image as T2, post contrast T1 image. What is the diagnosis? What is the cause of expansion of the cord and bracing intensity T2? The question very, as Anbarasu pointed out, the questions are specific and you have to make specific answer because within 1 minute you have to answer. I may be slightly faster. Okay. The 10B, almost similar, 33 years old, progressive weakness, lower limb, 6 months. And there is a abnormality here and post contrast. Okay. What is the diagnosis? What is the cause of expansion of the cord and what is the cause of bracing intensity in T2 image? Each carry 2 marks, 2 to 4 marks, each questions. Okay. Yes. The third module, more of no critical value and more clinical value added cases. More, but the critical and important thing, critical. That's why here also it carries a clinical value also, order case. So we must know. So here the question is clear. This is a 5 into 5 marks, 5 cases, 5 mark each. So 25 marks because more clinical value order case we must know. Okay. Here only one slice. What is the abnormality and what is the clinical significance? You can treat it as say this Oski, or maybe you can have this all exercise. The question 1 is 2 marks and question 2 is 3 marks. What is the clinical significance? Because most often we report often the paranasal sinuses, but sometimes some critical finding will be very important to mention. Okay. Okay. Question number 12. There is a patient having 23 years old, non-hypertensive, fainted in the office on examination, CV sinus normal. And there is abnormal, there are multiple areas involvement, T2 image, flare images, and there is a angios. What is abnormality? What is the clinical significance in this case? So we have to inform the clinicians why this abnormality is there. That's why. Okay. Okay. Now we'll move on to the case number 13. What is the, here is the axial zoomed images. Okay. There is abnormality here. What is abnormality here? What is the clinical significance? See carefully. There is a symmetrical areas there, but maybe some area may be very important. That's why always compare with the contralateral side. You may get the abnormality. Okay. What is the abnormality and what is the clinical significance? When you say clinical significance, there is more marks. Okay. 13, 14. So this is very obviously there is finding. What is the abnormality and what is the cause? You can see that zoomed images. What is the cause here? The etiological factor will carry more marks. Okay, 14. The last case, case number 15. What is abnormality? See carefully. There are some finding non-contrast images. We have to make diagnosis. We have to make diagnosis. At least say mention about the various abnormalities. What is abnormality? What is the extent and what is the mode of spread here? That's important. That carry the more weightage. So always when you see one particular image, there will be some abnormal finding, but you have to say what is the full extent to make a diagnosis, and it will carry the more clinical significance. Okay. Okay. So module number 1, 5 into 4, 20 marks. And module 2, 5 into 8, 40 marks. Then will be module 3, 5 into 5, 20 marks, totally 85 marks. Okay, we will move on to the case now. Okay, now we will move on to the case. Okay, we'll start the answer. Answer is here. We'll start. Okay, so module 1. Okay, we will start the case number 1. Here is the first case and first B, 1A, 1B. And what is the abnormality here? We can just quickly will go through cases. Here this is a case A and case B. Though both are similar, but there is abnormality. You can see abnormality. So here there is a soft element here, and there is something in the bone window, and as well as you can see this. Okay, we will show the case number. This is a bone erosion. You can see bone erosion. You can go to the pointer option and the pen, and you can see that no, there is a erosion. This erosion can occur. Any lesions may be invasive, fungal lesion also. Okay, fungal lesion also can have their appearance. But important thing, and there is a soft tissue mass. There you can see the some soft tissue element seen alone. Okay, and this is a around the extending infiltrating around, and the here lesions actually not only here. This is a pterygopattern fossa normal here, but pterygopattern fossa is abnormal. So loss of normal fat plane here. So diagnosis will be no more infiltrative and bone erosion. Diagnosis will be maybe some malignant lesions, adenoid cystic carcinoma can extend along this way. Okay. Adenoid cystic carcinoma contrast enhancement, nicely seen that pterygopattern fossa normal here and pterygopattern fossa abnormal, expanding and enhancing lesions. Okay. So lesions almost like a lesion look like a sinusitis, as is seen case. The case number B is just only sinusitis. So sometimes sinusitis can mimic a lesion, which is a more malignant process, but as infiltrated in the bone, and there is a soft element, and there is a spread across the nerve also. There is a V2 involvement of the pterygopattern fossa involvement. Okay, so we have to see carefully in the practice and as well as exam. Case number 2A, 8 years old short stretcher, and this is a 6 years old impaired vision. In this case, case number 2B. We'll go one by one. 2A, you can see T1 image. There is a thickening of the, this is a young child. Okay, this is a, as I said, 8 years old short stretcher. So here the lesion is actually mainly involvement of the, here this is the near the infundibulum and tuber cinereum. Typically tuber cinereum, because of tuber cinereum involvement, and the pituitary appears very small. Okay, look at the very small. That's why patient having short stretcher. Basically, this is a lesion in the hypothalamus involvement, and this is a mainly enhancing lesion at the level of the tuber cinereum. This is nothing but LCH, Langerhans histiocytosis. Typically, Langerhans histiocytosis is involvement of the tuber cinereum. This is important point here. Important. This take the classical area involvement. The other areas involvement, the tuber cinereum. There is a mild thickening of the infundibular stalk and the frank hypothalamic mass centered in the superior aspect of the stalk. Okay, that of course there is involvement of the hypothalamus, and this is the involvement of the optic chiasma optic nerve also. So this is Langerhans histiocytosis causing. Sometimes the child may be present with diabetes insipidus also. Okay, so morphologically you have to mention identify the thickening of the infundibular stalk and the tuber cinereum enhancement, and this is a pituitary may be small, or posterior pituitary may be sometimes may be absent, or maybe we may not see, maybe you can see abnormally the posterior pituitary will be absent. Case number 2B, this is a similar looking lesions, but the lesion is a more anterior aspect. It is not in the posterior aspect of the hypothalamus. It is involvement of the exactly the chiasma and as well as the superior aspect. Okay, look at the lesions involvement of the chiasma involvement. You can see some more images. There's a more chiasma involvement, and there's some area dark intensity is hematomatous tissues. You can see the hematomatous tissues, which is non-enhancing, and there is enhancement here. So this is also young child. This patient have seizure, and this is nothing but a hypothalamic gliomas. Okay, this hypothalamic gliomas usually involve the hypothalamus region involved in the optic chiasma and optic chiasma, typical area. So always see the epicenter of the location is important. The case number A is actually involved with the infundibulum and tuber cinereum involvement. Here this optic chiasma and hypothalamus involvement. Always here the pituitary gland appears normal here. There is no abnormality of the pituitary gland as seen here. Pituitary gland normal enhancement. So this is a hypothalamic glioma, whereas the first one is the Langerhans histiocytosis. Okay, you can see the histiocytosis again. Okay, we will move on to the next case. Okay, this is also another companion case. You can see that no hypothalamic involvement. Here is important thing, there is a involvement of the optic tract also. Optic tract also. Okay, optic tract also involved. And there is a here, I'll show the anatomy very clearly here. Okay, this is the mammillary body. This is the tuber cinereum involved in the Langerhans histiocytosis, whereas hypothalamic and this area involvement in the hypothalamic gliomas are involvement. Commonly neurofemoris NF1. Okay, so chiasma may be involved. Whenever the hypothalamic posterior aspect involvement, pituitary neurohypophysis may be involved. Okay, so this hypothalamic gliomas. We will move on to the case number 3. It's 55 years old headache, and the lesion is actually I already mentioned about this is the lesion. Okay, and important thing here the diffusion vector image is dark, and the ADC will be bright on the other hand. Okay, and thickened wall enhancement. So let us move on to see case number B. Okay, we can see that this also has similar appearance. We'll come on how to explain. So clue to the class 3A. Here the lesion appears low signal intensity on T2 image. You can see the T2 image low with no blooming. There is no blooming, so this is not a hemorrhage area. Restriction, no restriction because no diffusion dark and reverse of no. Here ADC bright. So enhancement is very thick wall rim enhancement. So lesion, what are the lesions? Can occur low signal intensity area. Low signal intensity highly cellular lesions, high protein areas, or maybe infections. That is a fungal or tuberculosis. Hemorrhage also can occur. Calcium, blood flow, they all can occur. So here this the different diagnosis can be lymphoma, tuberculosis, and tumeficate MS or resolving hematoma. But GRE is not there. GRE is not a blood. So it is not infarction also. It is a diffusion. It is not restrictions. The diagnosis will be tuberculosis. Tuberculosis very common. As Anbarasu pointed out, tuberculosis any form can occur. This is typical tuberculosis lesion. Coming to the third B, it almost look like similar, but there is here hemorrhage there. Okay, there is a gradient image appears dark and T2 image. Important clue here, this is sinuses. Look at the sinuses, which actually there's no, without contrast, we are seeing there is an abnormal bright intensity in the lateral sinus. So this is nothing but lateral sinus thrombosis. Okay, if you contrast, there is a filling defect and the cord sign is present. There is a hemorrhagic infarction with there is thrombus with venous infarction. So the lesions look similar always. Coming to the case number 4, 4A, there is large infiltrated lesions as is seen here. Okay, here the lesion become more infiltrated and there is hemorrhagic areas and more ill-defined infiltrated nature. So diagnosis is nothing but infiltrated tumor. Most likely this is an oligodendroglioma. I'll explain this one. This is why this oligo, because no, here the T1, T2 and flare almost equal, no mismatch. And this is the oligodendroglioma is 1P 19Q correlated image. So correlated tumors. So most likely oligodendroglioma. 1P Q19Q correlated means oligodendroglioma. I will explain to later. So infiltrative lesions. This is a oligo infiltrative. So this is anaplastic oligo. Okay. Another case look like similar, but look at these areas. Here this is T2 dark and contrast enhancement. Okay, we'll go through. What will you do next? It's almost look like a tumor, Can you do tumor biopsy or additional sequences or a DSA? What exactly? Suggest clinical correlation. That is not a correct word. Always go through images. There is something here. Okay. The clue is actually, there is a central, there is a cord sign kind of thing exactly in the one of the cortical vein that give a clue. That is a, so what will do? MRV. If you do MRV, actually seen there is a defect. There is a superior sinus thrombosis, almost like a mimicking a tumor. So always go through the every images when subtle sign. The subtle sign give a clue for a diagnosis. Okay. So case number 5. This patient had head injury. As evidence by there is area, air, and the normal lens. Normally you can say lens here, but the lens not seen. So the lens is dislocated here. Okay, this is case number 5. Dislocated lens, and this is air actually because the patient had injuries. Okay, but another case, you can see that now this is a 18 months old. This white eyes reflects one of the common feature you will get expectancy. This is nothing but a retinoblastoma. Retinoblastoma can go with along with the other tumors. Here intraocular lens with the calcification in a young child, always think of retinoblastoma. Retinoblastoma can get multiple, you have to show the extent of the tumor, involvement of the optic nerve, optic chiasma. Sometimes we can get in the multiple tumor in the other pineal region also. Okay, so depends on this one. There is a type of tumor also, retinoblastoma also well described. This is not the form. I'll show some other such. Case number module 2. This is OSCE module. What is important now? Okay, we'll see. See, case number 6A and 6B, they're all both are glial tumors. We already said. What is the radiological feature? What is the radiological sign to suggest? As already mentioned about here, important signs called T2 flare mismatch sign. The T2, always T2 and flare will be almost similar. So there is no mismatch. If there is a mismatch here, if there is a mismatch sign, most likely this is a if there is a mismatch sign, most likely it will be it is a astrocytoma. This is the IDH wild type of astrocytoma. Okay, so always mismatch is there. If there is mismatch is not there, if there is mismatch not there, then will be it is negative for this ideal wild type. Okay, IDH wild type will be negative for mismatch sign. Positive will be always astrocytoma. So this is astrocytoma. Okay, T2 mismatch sign is highly specific for the astrocytomas, particularly IDH mutant astrocytomas. Almost 100% specific. But there are some certain less than 50%. Is there less than 50% some areas, focal hypodensity areas, or maybe cystic area? You should not mistaken as that. So always important thing. So whenever diffuse gliomas, we can see whether this patient is IDH mutant or IDH wild type. Okay, the IDH mutant tumor will be 1PQ19 coagulated, okay, or NPQ intact. 1P19Q coagulated means oligodendrogliomas, 1PQ19 intact astrocytomas. Okay, and whereas wild type again will be depends on the EFGR, that is the endothelial growth factors. Then will be molecular GBM will be there. So here the positive mismatch sign, very classical of GBM with IDH mutant. So what can say only IDH mutant because it's mismatch, positive for mismatch. T2 it is dark areas and this is T2 is bright areas and T2 and the flare is not it's not the corresponding dark areas. There is mismatch between the T2 and there's no flare images. There are some bright intense areas. This is a typical positive flare mismatch of IDH mutant type. Okay. Here is another example. You can see the T2 image and flare images. Both are almost matching. Okay. So the negative T2 mismatch, the negative mismatch that is is matching. So there is most likely this is the IDH mutant wild type. Okay, IDH mutant wild type. Okay. Whereas here T2 flare negative T2 mismatch sign, T2 flare mismatch sign. Okay, here both are actually T2 and both are almost similar. There's no mismatch, so that's called negative T2 flare mismatch. That is, so it is a oligodendrogliomas. Okay, so we'll move on to the next one, case number 7. Here this is 6 years old male with seizure. And what is the two important finding we asked for? One is actually, we say there's not typically, there is multiple signal void areas I can see here. This signal void area is nothing but this is a, and there are IV sign. There's IV sign, classical sign, IV sign. You can see the edge of the areas, multiple signal void areas also. So with multiple infarction, think of always this moyamoya disease. The typical pattern of IV sign, one of the sign for moyamoya disease. What you'll do, if you do MR angiography, you can make a diagnosis of, again, MR angiography says multiple collateral channels. If you give contrast, you will get enhancement of the collateral channel arterial feeders. Okay. The question asked for similar case, you can see the multiple signal void areas are seen here. This is a signal void, nothing but a calcification in the cortex. Here this led to what? This is nothing but a Sturge-Weber syndrome. Sturge-Weber syndrome with gyriform calcification. Gyriform calcification is related to a leptomeningeal vascular malformation with the calcifications. Okay, as you see in here, there is reduction volume of the hemisphere. Okay, both are will be no, we get collateral channels. That is no, here this venous collaterals, there is no moyamoya arterial collateral also will have enhancement. Okay, move on to the case number 8. The female present with altered behavior, no fever. Okay, important thing, what is most likely diagnosis here? This bilateral symmetrical changes following the insular cortex and frontal lobe. Okay, you can appreciate very well in the coronal images. The question is actually here, you ask for what is the most likely diagnosis. Diagnosis will be autoimmune encephalitis because it is look like almost like herpes. Most of you written herpes because no fever. Here due to this is a autoimmune process. This is the autoimmune process. You can get two type. I'll explain to you. What you will expect to see, or maybe what are the things, what are the confirmatory tests we have to do? Other tests like any other tumor in the ovary tumor, testicular tumor, or you can get lung tumor or NMDA receptor antibodies. You have to see, check. Okay, this is a more diagnostic. And always this patient will be present with altered behavior or psychological symptoms. Okay, so autoimmune encephalitis, a well-known entity. Okay, it had divided into two broad categories, and one is a paraneoplastic lymphencephalitis related to some tumor with producing antibodies. Non-neoplastic autoimmune encephalitis are reversible. This is related to neuronal dysfunction. Okay, this is due to extracellular antigen, NMDA receptor antibodies. Okay, the cause for the paraneoplastic condition can get small cell carcinomas, thymic tumor, breast tumor, ovarian tumor, they all can occur. Non-neoplastic paraneoplastic autoimmune encephalitis related to that is anti-N-methyl aspartic acid receptor encephalitis. Okay, so what is the differentiate point? So clinical history in autoimmune disease usually psychotic symptom, whereas herpes will be fever and okay, most important features. Usually here basal ganglia will be sparing, whereas medial temporal lobe, insular cortex, and the entire brain may be involved. Okay, here hemorrhage is more common in the herpes, whereas autoimmune encephalitis no hemorrhage. Here the lesions are only like a no restriction. Okay, but here this is a necrosis hemorrhage, so there is ADC low. So here this is the immune process like a ADM process, look like almost like a ADM process will be there in autoimmune encephalitis, whereas herpes will get more of ADC low. Okay, so we'll move on to the case number 8B. Almost similar case, similar like the lesions, but here patient having a pituitary lesions are treated with radiotherapy. Okay, typical radiation port. Okay, most diagnosis will be like radiation induced encephalopathy. Okay, here this post radiation encephalopathy in a case patient present with a tumor here in the pituitary, and what are the importance here? Bilateral symmetrical changes, leukoencephalopathy. Okay. Okay, you can see some of the images, particularly bilateral symmetrical nature, and always should not mistaken as a herpes encephalitis or autoimmune encephalitis, because go through the images and this patient having treated with any radiotherapy or chemotherapy. You have to ask for dig the history. Case number 9, what is the diagnosis? Very obviously there is Charey malformation. Here important thing, there is herniation of the tonsil, herniation with augmentation of the foramen magnum that result in and the obstruction to the oral cord. Okay. Okay, here this is here the foramen magnum obstruction causing syringohydromelia. Okay. So here Chari malformation producing foramen magnum with hollow cord involvement. Okay, in this case. Whereas here, this is a case number 9B, almost similar, but look at the areas. Somebody asked for doubt also today. Here the cord is actually, see that, look at the T1 image, there is a syringe here, whereas the mid dorsal level and lower level cord is not clearly seen, and there is the obliteration of the cord with the subarachnoid spaces, and there is an enhancement. You can see the enhancement nicely here, the enhancement of the meninges, okay, with the obliteration of the subarachnoid space, with there is syringe formation. It should not mistaken as a congenital syringe or syringohydromelia and occurs in the Arnold Chiari malformation. Here thickened meninges, okay, it is nothing but spinal arachnoiditis. Well, you can see nicely the arachnoiditis with the obliteration of subarachnoid space, and there is syringe formation. You should not mistaken as a tumor also. Okay. The enhancement will be non-uniform. The obliteration of subarachnoid space, thickened, and there is something clumping of the nerve roots. Okay. And the varying phase of the dorsal intensity may be related to a chronic exudate of this case of tuberculous meningitis with arachnoiditis. Here, the important thing is this leptomeningeal adhesion causing spinal CS obstruction resulting in syringe formation, whereas obstruction at the foramen magnum in the Chiari malformation. Case number 10A, almost patient had progressive weakness lower limb. We saw this expansion of the cord, and there is multiple single void areas are seen, and this is nothing but diagnosis AVM. It's a spinal AVM, dural AV fistula. The dural AV fistula, we can see nicely multiple single void areas are nothing, and the cord is expanding and the enhancement. What are the cause for expansion? Here, this venous plexus will be dilated venous engorgement, resulting in congestive hypertensive myelopathy occurs in spinal dural AV fistula, almost likely tumors almost. So here prominent serperineal vessels, very characteristics, and there is diffuse multi-level intramedullary hyperdensity related to very important finding, and T2 will be hyperdense, and most contrast enhancement will be there, because due to hemorrhagic infarction, or maybe T2 at maybe deoxyhemoglobin. Okay, so maybe intramedullary enhancement can see because due to breakdown barrier of the blood-brain barrier of the capillary permeabilities. Okay. Case number 10, you can see that this is an expanding lesion. This is a tumor infiltration causing infiltrative tumor causing expansion of the cord. Case number, the module 3, just quickly we'll go through. Here is what is case 11. You can see that this is called nothing but this is called ONOD cells. ONOD cells, actually this is nothing but there's a posterior ethmoid cell will be communicate the sphenoid sinus and the sphenoid. Here important thing you have to see that optic nerve maybe surrounds. Okay, you have to mention the report optic nerve. Okay, why it's important? Always cause optic nerve frequently in intrasinus course. So whenever any case comes with sinusitis, because the increased risk of optic nerve in doing face surgery. So important thing, you have to see these abnormalities in a normal picture. So important thing here. So you could go through the images, Bhavana's article nicely, IGRA article. You can see some varying portion of the optic nerve may be exposed in the sinuses. It will be vulnerable for when you're doing face surgery. Case number 12, young patients, non-hypertensive, multiple infarctions. Here is important findings actually because of vessels. So because it is not a hypertensive, it's not an embolic. Important thing you have to mention about patient may be hypotension because their abnormal vessel here. You can see that persistent trigeminal arteries here. The typical radian appearance there is a typical area of appearance here, persistent trigeminal artery with the hypoplastic positive, that is vertebropatellar system causing multiple infarction. So a patient should not get hypotension any point of time. So you have to mention the report. Okay, persistent trigeminal artery with the multiple infarctions. Case number 13, very important finding here. Okay, so you can see nicely there's bilaterally the right side, that is left side, right side is normal, left side there is a aberrant internal carotid artery. And very important aspect is the otoscopy should not mistaken as a tumor, a malignant tumor or maybe paragangliomas. So this is very vulnerable. You have to see carefully. When your mind knows, the eyes will see, definitely going to see. Okay. So aberrant internal carotid artery, we can see as is seen in the middle ear cavity, just lateral to the cochlear promontories. These are all related to important anomaly. This because of choroidal pathway resulting from the involution of the normal cervical portion of the internal carotid artery. Two vessels are responsible because only here there will be an inferior tympanic artery and carotid tympanic artery. Both are get unexposed vessel. That portion where actually exactly horizontal segment of the petrous portion of the internal carotid artery. This anomaly may be associated with persistent stapedial artery. You have to go through it carefully. Okay. So what is the importance? Maybe patient may be present with the tinnitus, but often retrolymphanic vascular masses. They should not be mistaken as a paraganglioma mass or should not take for biopsy. It will be disastrous. You have to mention the clinical and the imaging report. Last but one case, patient having lot of hemorrhage, and this very classically, if you do sections, you can see there is a small aneurysm. So this is nothing but a subarachnoid bleed with intraventricular bleed. There is a bleed, the parenchymal bleed, there is a partially thrombus aneurysm, which is responsible. So whenever they bleed, you see always what is the root cause. Maybe hypertension bleed, or maybe coagulopathy status, or maybe aneurysm. So always will be, you have to saying patients aneurysm, you have to always see carefully. Okay, this is partially thrombus aneurysm. You can see where the sigmoid areas, maybe areas where patent area. Last case, what is abnormality? You can see the abnormality. You can see nicely that the superior artery fissure, there is hypotenuse areas, and see the obliteration of the spaces. And if you see carefully, there is a lesions involvement of the other area also. Okay, because there is a V2 involvement and there is the fossa involvement, V1 and V2 involvement. So here there is a patient having involvement of the inferior orbital fissure and foramen rotundum involvement, and lesion having contrast, there is an area nasopharyngeal lesions. So the patient having this is nasopharyngeal CA with the V1 and V2 involvement, and this is perineal spread. Okay, always go through carefully. Important, last 1 minute, I'll go through quickly. This is a successful radiologist, you should know, elicit always possible clinical history and tailor the radiological technique as per the clinical scenario. And the interpretations, always location. Epicenter of the lesion is always important to compartment at arises. Which arises from which compartment? What is the extent? What is the pattern of spread? Get familiarity of the radiological pattern. Never stop, you find one lesions. Okay, never get search of certifications. Okay. So elicit the possible history, interpretation, extent, get familiarity of the radiological pattern. Prepare for do standardize and report. A report should be a clinical relevance, always without no use. Always interact with the clinical colleagues and get follow. Important thing, audit yourself. So these are for a successful radiologist. Okay. Okay. Thank you very much. If you have doubt, you can send it across to my email. I'll answer because time already up. Okay. Thank you. Thank you.
Thank you. Thank you so much, sir. Thank you, sir. I think some questions are there in the
I'll
chat,
do
sir.
later,
You can later answer them also
other
if
person.
you want. Yes. No, you can keep answering, sir. This next session will start. You can just answer, type the answer in the chat if you want. Yes. Any relevant question? Yes. I now next welcome Dr. Vijay Bhaskar. Dr. Vijay Bhaskar Nuri is a very senior radiologist from Hyderabad. Sir, welcome to the session.
Thank you, Murli. Thank you very much.
Can you hear, sir? Yes, sir. Yeah. So, sir will now discuss the spotters on CNS and CVS and chest radiology. Sir, you can share your screen, sir, and we'll start off.
I already started sharing.
No, sir. We're only seeing you. Let's click on share the screen. Turn screen share on.
Okay. Is it seen now?
No, sir.
Because I am already sharing the screen now.
Can you not share and again try sharing, sir?
Is it okay now?
No, sir, we are only able to see your video. I mean, your video, not the screen.
Shall I log in again if you want?
Yes, yes, sir, that will be better. Yeah. Yes, sir. Now we are able to see your screen.
Now you can see.
Yes, sir.
Thank you. Thank you very much, Dr. Amarnath, Dr. Murli, and all Tamil Nadu Pondicherry chapter for giving me opportunity to show some of the interesting cases in spotters for students in chest and CVS. So it automatically go forward. 40 questions are there. 40 spotters are there. They automatically go forward in 20 seconds each. I hope the students will assess themselves based upon their performance. They write down the answers carefully for each question. They can assess themselves by giving 4 marks to each, 160 total, and very poor grade if 20 to 15. So this is the first case. 53-year-old male with CAD presented with shortness of breath. You can write the modality and what is the abnormality. Murli, are you able to see the screen? Okay,
Yes, sir. We are
thank
able to see it, sir. Yeah. Sir, on your screen, that hide button, if you click, we can remove that also, sir. Next to stop sharing, one
Yes.
hide button is there, no, sir? Just click that, sir. Yes. Thank you, sir.
For all the students, we have started with easy cases first. That is CT and MRI. And we'll go to conventional radiology, difficult cases in the last. So that is the order of the day now. Most of them are pretty straightforward. I hope most of the students get right. Murli? Murli,
Yes, sir.
is it going?
Yes, sir. Yes, sir. We are at 7th case.
Yes.
Okay.
Most of the cases are self-explanatory actually. Murli, can you see the video also?
Yes, sir. Video is playing, sir.
Okay. Some are very straightforward, and there are a lot of clues also in the given images. So please go through all the images carefully, and your clues also are there. There are very specific clues in most of the images. Some are very straightforward cases because they are all exam cases. We usually take a penetrated view for cardiac image, especially cardiac related issues. We take a penetrated view. Penetrated view, especially to look at the chambers and other abnormalities. So this is a penetrated view where we are seeing the dorsal spine also much clear. So look carefully in the penetrated view. What abnormality can you pick up? This is a softer film to look at soft tissue abnormality. The clinical details are also very important, especially to differentiate some of the cases, abnormalities in the lungs. So we come to an end to the spotters showing the cases. I hope all of you have got enough time to write the answers. Let's go to the answers and check out what are all the cases and what was happening in all these cases. So let's go to case 1. Now this is a cardiac MRI, post-gadolinium studies, delayed gadolinium studies. Patient had history of coronary artery disease. This is a short axis and this is a 4-chamber view. You can see that there is transmural enhancement of the anterior wall, and septum. So transmural enhancement is suggestive of ischemic etiology, and that is vascular territory, LA territory, and that's an infarct, transmural infarct. And by the pattern of enhancement, hyperenhancement patterns, we differentiate between ischemic and non-ischemic causes. Transmural and subendocardial are always ischemic, and non-transmural, midmural, subendocardial, subepicardial, and pachymural are all non-ischemic causes. Ischemic causes are mainly subendocardial and transmural involvement. And number 1, number 2, it's also involvement of the particular vascular territory. For example, here, anterior wall and septum are LA territory. Inferior wall is RCA or L6 territory, and lateral wall, this lateral or posterior wall, is circumflex territory. So here you can see that involvement is predominantly in the LA territory. So one vessel territory involvement and delayed transmural enhancement is very typical of a scar or an infarct. Now, hypertrophic cardiomyopathy. Typical presentation is with syncopal attacks, and this is you can see that this long axis and the short axis use severely thickened myocardium, more than 12 millimeters, obliteration of the systolic obliteration of the endocardial cavity at the apex. And how do you diagnose hypertrophic cardiomyopathy? In adults, 1 or more iliomyocardial segments 15 millimeters or more in thickness. In children, wall thickness more than 2 standard deviations. And in relatives, you have skin relatives also, because it is also autosomal dominant, runs in families, and it can produce obstruction of LV outflow tract, and this is the cause of sudden cardiac death in less than 30 years old. And most often you see systolic anterior motion of the mitral valve and left ventricular outflow tract obstruction. All these are typical features of HCM or HOCM, hypertrophic obstructive cardiomyopathy. Remember, more than 50 millimeters is definite, more than 12 millimeters is doubtful of hypertrophic cardiomyopathy. And this is a post-contrast study of the same case. You see late gadolinium enhancement of the myocardium because of fibrosis occurring because of small vessel ischemia. You can see the fibrosis, and if there is more than 30% of scarring occurring in the myocardium, it's a very bad prognosis, and the patient will develop cardiomyopathy, and then he has to go in for heart transplantation. Now, this is a very typical case of anomalous origin of right coronary artery from left coronary sinus. You can see here that this left coronary sinus, LAD and RCA are coming from the same coronary sinus, number 1. And number 2, this has a interarterial course between the pulmonary artery and aortic root. So this is a possible malignant course, because whenever there is exertion, whenever there is dilatation of aorta or pulmonary artery, the artery can get compressed and they can go for sudden death, or they can even develop ischemia, cardiac ischemia, myocardial ischemia, because of compression in interarterial course of right coronary artery. And this is a diagram which shows typical what we have seen a similar case, that the RCA arising from left coronary sinus, and then there is a interarterial course between aorta and pulmonary artery. These are likely malignant course of the coronary artery, where they can get compressed between the two arteries. Either they can develop sudden infarction or they can develop ischemic kidney. Now this is a post-CABG CT angiogram, and you can see that Lima graft is occluded. There is no contrast participation of Lima graft here. And whereas distal LAD or runoff LAD is patent, it is normal in character. So usually the Lima graft occlusion occurs whenever there is a competitive flow phenomenon. What is competitive flow phenomenon? Competitive flow phenomenon is when the native artery opens up, native LAD opens up, the antegrade flow of good pressure will slowly block the reduced flow in the lima artery or internal memory artery, left internal memory artery. And that is the commonest cause for occlusion of the lima graft. And the other common cause is poor technique, occlusion of the anastomosis. Per se, the lima graft does not get occluded because it is protected well by the muscular way, does not get affected. Now, this is classical picture of aortoarteritis, young female with hypertension. What you can see is transmural thickening of abdominal aorta and delayed enhancement. These are delayed studies. This is arterial phase, delayed study, delayed mural enhancement. You can see delayed enhancement. You can see the surrounding enhanced thickened wall shows delayed enhancement. Typical. Now, aortoarteritis can be classified type 1, 2, 3, 4, 5, depending upon the classical type is aortic, is solely the aortic arch branches. Then involvement of ascending aorta and branches. Then involvement of thoracic aorta and abdominal aorta. Then only abdominal aorta and renal arteries. And type 5 is all aortic sepals. So type 1 is classic variety where you've got involvement of the arch branches only. And that is classical typical. Patient presents with absent pulse in either of the limbs and you don't see a subclavian artery. That is typical type 1 of classic type of aortoarteritis. This is a classic case of coarctation of aorta. 18 years old male with hypertension and disparity of limb pressures because there is a lower limbs are hypoperfused because of the coarctation of aorta there. There's a delay in the pulse, low volume pulse, delayed appearance of the pulse in the lower limbs. And this is a typical coarctation of aorta. You can see the jet also there. The stenosis in the aorta is occurring distal to the left subclavian artery. So, and these are all multiple collaterals. So, how do you classify coarctation? Infantile, adult forms. Adult forms are always mostly abrupt stenosis of post-ductal aorta. That means wherever PDA joins, it is post after that. Infantile forms can be preductal. That means before the union of the PDA. And one more important point is infantile forms can be associated with hypoplasia of the arch. So this is an infantile form. This infantile form, you have a again post-ductal, but there is hypoplasia of the arch. There is coarctation here, but there is hypoplasia of the arch. So that's how we differentiate between infantile variety and adult variety. Adult variety is always post-ductal and there is no hypoplasia of the arch. Now, this is a typical case of analo-aortic ectasia. What is analo-aortic ectasia? Symmetric dilatation of aortic root and ascending aorta with effacement of sinotubular junction. So the sinotubular junction, sinus and ascending aorta, there is a sinotubular junction at this level. This is effaced completely, and there is bulbous dilatation of aortic root and sinotubular junction, typical of analo-aortic ectasia. And this occurs in all these conditions, connectivity disorders like Marfan's, Ehlers-Danlos, homocystinuria. Bicuspid aortic valve is very commonly associated with earlier we used to see with syphilis, Oshin's imperfecta. So whenever you look at analo-aortic ectasia, also look at bicuspid aortic valve because most often it is there. Now, when you consider aorta is enlarged, more than 4 centimeters, ascending aorta, and descending aorta is more than 3 centimeters. Now, what is ectasia? Ectasia is any dilatation up to 1.5 times that of the normal vessel. So whenever there is a normal vessel, 1.5 times dilatation is known as ectasia. More than 2 times you got as aneurysm. And ascending aorta, the cutoff point is 4 centimeters, and descending aorta 3 centimeters, and ascending aorta larger than 5 centimeters, and descending aorta larger than 4 centimeters is definitely it is aneurysmal dilatation, and that needs any kind of further investigation and treatment. So always the cardiologists look at the ascending aorta and 2D echo, and 5 centimeters is cut off for them. 5 centimeters is cut off. Dilated is 4 centimeters. Aneurysm is 5 centimeters. More than 5 centimeters. Patient needs aggressive investigation and treatment. Now, this is a typical chronic dissection of thoracoabdominal aorta, and you classify dissection based upon DeBakey or Stanford. Stanford is type A and B, and DeBakey is type 1, 2, 3. So DeBakey type 1, 2 are come under Stanford type A, and Stanford type B is type 3 of DeBakey, that is only the descending aorta. Only descending aorta. Now, Stanford type A is entire aorta or only ascending aorta and arch vessels. That is type A. Now DeBakey has entire aorta as type 1, only arch and ascending aorta as type 2, and descending aorta as type 3. So whichever you want, you choose. Stanford is most commonly followed. Think for aortic dissection. This is the aortic dissection. True lumen, false lumen, true lumen. False lumen has a lot of thrombus, and usually when acute dissection, you differentiate between the true lumen and false lumen by whatever is located more medially, wherever there is thrombosis, wherever there is less flow, and wherever there is faint opacification of contrast. That's the false lumen. And then true lumen. And how do I identify true lumen? True lumen is identified by the presence of the intimal calcification also. Now, this is a 2-year-old child, failure to thrive and recurrent respiratory tract infection. What are the positive findings here? The right upper lobe bronchus is not visualized. Upper lobe bronchus is up there. There is mediastinal shift towards right side, hypoplasia of right upper lobe, and there's a classic scimitar pulmonary vein, scimitar sign, inferior pulmonary vein, right inferior pulmonary vein is joining the IVC. So this is a typical scimitar syndrome. There is also hypoplasia of the right pulmonary artery. Look at left pulmonary artery size, right pulmonary artery size. Hypoplastic right lung, upper lobe, shift of mediastinum, hypoplasia of the right pulmonary artery, and a anomalous pulmonary vein draining into inferior vena cava. So this comes under combined lung and vascular malformations or scimitar syndrome or hypogenetic lung syndrome, typical scimitar sign. Now, this patient presented with hemoptysis, recurrent chest pain and skin lesions. So skin lesions, ulcerations and aneurysm, you always suspect Behçet's disease. Behçet's is a multi-organ involvement connective tissue disorder. It's a vasculitis. It's a small to medium vessel vasculitis involving multiple organs, and one of the typical manifestations is that of a aneurysm of the pulmonary arteries and oral ulcerations, skin ulcerations. And this, whenever you look at aneurysm, de novo aneurysm of the pulmonary artery, two commonly suspected conditions are Marfan's and Behçet's. Marfan's and Behçet's. Always remember, very commonly produced pulmonary artery aneurysm. Now, this is a 14 years male with chest wall swelling, very typical swelling with multiple small ossific nodules in the chest wall. Diagnosis, all of you must have got it right. This is a low flow venous malformation. These are nothing but phleboliths within the venous malformation. And on MRI T1 and T2, T1 fat sat, lot of fat inside with hypointense nodules, calcific or ossific nodules. And on T2, because of the interfaces in the blood vessels, they produces bright, very bright appearance on T2 or T2 fat sat images, and on T2 weighted images especially. And this is typical of the venous low flow venous malformation of chest wall. And clue is the phleboliths within the mass. This is a very, very typical spotter. Volume loss of left lung, medially placed opacity with air bronchogram or bronchiectasis, typical of chronic left lower lobe collapse. And you don't see the fissure at all. You don't see the major fissure on left side at all. Completely shifted here. It's completely shifted here. So hyperinflation of the upper lobe and limula. So this is a typical case of chronic left lower lobe collapse with hyperinflation of the rest of the left lung. Now, children especially, when they come with dyspnea, stridor, whooping type of cough, you suspect foreign body aspiration, and CT scan is modality of choice. You can see that hyperinflated lung, right lung on the topogram, cutoff of right main bronchus. This is a mini image showing lot of air, subcutaneous emphysema, mediastinal emphysema, and lot of air pockets there within the lung parenchyma. So there is cutoff of right main bronchus distally because of foreign body aspiration, and this foreign body impaction, it acts like a ball valve mechanism. What is ball valve mechanism? The foreign body gets impacted there. Whenever patients take deep inspiration, the bronchus expands, opens up, air goes in. Whenever patient exhales, the bronchus closes, it shortens and relaxes, becomes small in caliber, so it gets trapped in. So bulb mechanism. In inspiration, air goes inside. In expiration, air gets trapped because it can't come out, because naturally also the bronchus collapses during expiration. So because of this air trapping or bulb mechanism, lung gets expanded, bronchi rupture, produce subcutaneous emphysema, pneumomediastinum, pneumatoceles in the lung parenchyma. So many things occur. The surgical emergency, CT is asked for do vertical bronchoscopy showing the cutoff there, and you have to have a complete picture. You have to give a complete picture of pneumomediastinum, surgical emphysema, and everything else. Now this is again a very typical case of shift of cardiac mediastinum towards left side, no lung parenchyma on left side, compensatory herniation of right lung parenchyma, mediastinum is shifted to left side, cardiac mediastinum to left side, pulmonary artery RPA is there, LPA is not seen. LPA is not seen. This is a typical case of agenesis of left lung. No LPA there. No lung parenchyma on left side. Compensatory herniation of right lung parenchyma. Typical agenesis of left lung. The proof is absence of left main bronchus, absence of left pulmonary artery. Is the proof to say this agenesis. Now, baby presented with recurrent respiratory infections. On X-ray, you see a large opacity with cavities in left lower zone. On CT, you see a large opacity with central cavitation and fluid distended cavities, air distended cavities. And on angiogram, the left lower lobe opacity is draining into the inferior pulmonary vein, and there is also a systemic pulmonary artery supplying the left lower lobe lesion. So this is a typical intralobar sequestration of left lung. How to differentiate between intra and extralobar? Extralobar variety commonly drains into azygos system, portal system, subclavian or intermammary veins. Intralobar typically drains into inferior pulmonary vein. That is a very typical differentiation between the extralobar and infralobar. And then the hybrid lesion can be there having anomalous systemic arterial supply. That means the intralobar can have anomalous systemic arterial supply, but usually the extralobar will have the systemic arterial supply. They have own pleural lining, drain through systemic veins, and receive systemic arterial supply. So intralobar also can have, occasionally they can have the systemic arterial supply, but the draining vein is very important, where you see that the opacity, the lesion in the left lower lobe is draining into left inferior pulmonary vein, and it also has artery supply from the systemic arterial supply. So that is an intralobar sequestration. All of them come under combined pulmonary airway vascular malformation. Now, what is the typical chest X-ray finding? Snowman sign or figure of 8 sign, supracardiac TAPVC. It's a spotter, supracardiac TAPVC. And what is supracardiac TAPVC? The entire pulmonary veins drain through left to vertical vein, and the left to vertical vein gives this appearance of a left-sided superior mediastinal opacity, and the dilated right SVC gives rise to right superior mediastinal opacity. So the upper limbs of figure of 8, upper right is found by right SVC, and left is found by the left vertical vein into which all the pulmonary veins are draining. So that completes the figure of 8. One lower limb of figure of 8, upper limbs of figure of 8, right SVC, innominate vein, and left vertical vein into which all the pulmonary veins drain into. Figure of 8 or snowman appearance. Now, this is a known case of mitral heart disease. You can see cephalization of the pulmonary vessels. Pulmonary veins are draining. Pulmonary veins are more in the upper lobes than in the lower lobe. You can see lower lobes here, upper lobe. In upper lobes, there is a lot of pulmonary vessel diversion when compared to lower lobe. This is known as cephalization of pulmonary veins, typical of pulmonary venous hypertension. When pulmonary venous hypertension grade 3 becomes pulmonary edema. So this is a grade 1 pulmonary venous hypertension, that is known as cephalization of the pulmonary vessels. There is cardiomegaly, there is right heart enlargement, RA and RV enlargement. mild MPA, dilated aorta, and also
Hello, can everybody hear me? If you can put on the chat box, if you can hear me, while we are waiting for Dr. Vijay to log on. Okay, great. So I will take over while Dr. Vijay is trying to get, I think the connection is maybe from his side because I'm able to get the connection and the hearing. So good afternoon, everyone. I'm from Elsevier, and I'm here to give a short session on our RAD Primer solution, which is our comprehensive learning tool for radiology. Before I begin, I wanted to thank the IRIA for giving me this opportunity, as well as Dr. Amarnath. And what I'm going to do is I'm going to start with a few slides to give you an introduction, and then I'll jump into the demo. We'd also like to offer a 1-month free trial for everyone or anyone who's interested. So at the end of the demo, if you are interested, you can get in touch with Dr. Murali, and he will give me the list, and we will try and get that done as quickly as possible. So I'm going to share my screen. So again, welcome to our session on RAD Primer. Before we begin, I want to just take a quick minute to acknowledge the trying times we are in, that we have to do all this remotely. And I've been listening in all the sessions earlier, and they've been amazing. And it's unfortunate that bottlenecks can cause such a big issue. I hope Dr. Vijay is able to get back on, and you'll be able to finish the spotters questions that you were reviewing. But in the meantime, I wanted to acknowledge these times and hope that everyone is safe. We at Elsevier salute everyone in the front lines of the epidemic. And from our side, we've been supporting this fight by making all the COVID-related material available for free on our Healthcare Hub website. So I'd encourage all of you to go in there. There's a lot of interesting material from order sets to patient engagement. And I have a link to that at the end of the presentation. We've also seen that because of this pandemic, there is an increased demand for remote learning. The pictures on the left are from a university in Japan that wasn't able to hold its graduation ceremony. So you see that they actually ended up getting robots, and they have tablets with the graduates' faces in the front, and they use that to display the degrees or give the degrees. And you can see on the right that the poor graduate student is sitting in front of his computer and trying to take in on that whole process. We hope this doesn't last. We hope we're able to meet in person. But in the meantime, I will start with a brief history of Elsevier. Elsevier has a 140-year history of publishing with a focus on science, technology, and medicine. Each year, we publish over 470,000 articles in about 2,500 journals. Our archives contain over 16 million documents and around 30,000 ebooks. And just last year, our total yearly downloads were greater than 1 billion. More recently, though, over the past 2 decades, we have been harnessing technology to leverage all this content that we have and create digital tools to serve our customers. So now we are a leading provider of information analytics that helps science, technology, and healthcare professions like you make better decisions and deliver better care and make groundbreaking discoveries in research. Digging deeper into radiology, we have particular strength with our diagnostic imaging series, as well as books and journals. So this is my last slide on Elsevier, but this summarizes the various evidence-based clinical decision support solutions that we have to empower healthcare professionals across the spectrum. I've highlighted the 2 in yellow for what we have in radiology. So StatDX is our diagnostic decision support tool for practicing radiologists. And RAD Primer comes under our learning and competency management program to enable radiology residents with the latest updated content that is structured in such a way as to accelerate learning and test preparation. So I'm going to stop right here and see if anyone has any questions. Let's go back to my. So I will actually like to ask you what are the resources that you use. So I've created a poll. I don't know if you can see it. If you can see the poll, I'd appreciate a response. I just want to know what kind of training tools that you are currently using. So it's still going on. The poll's very interesting. I think you can probably see the results, but a lot of people are using books, journals, Google, actually books, journals, and Radiopedia end up being the most. I think the biggest one is Radiopedia. So that's interesting. Well, I don't know if you know about StatDX, but StatDX is the gold standard in terms of reference support. And for radiology, I'm going to now go to the demo. This is the login screen. And when you log in, this is the screen that you see. And the advantage of RadPrimer is that it basically collates all the different things that you need to know into one curriculum. And we basically, actually before this, I just want to have a couple of slides that I forgot to do. So yeah, so this is a brief overview of RadPrimer. It is a comprehensive online radiology curriculum, and it has 2 levels of learning, basic and intermediate, covers all the different rotations. These lessons are coupled with practice questions, so you can learn as you go along through each of the rotations. And then at the end, you can also measure and monitor your progress to understand if there's any gaps in your learning. So it becomes very objective for you to manage your own training. This is the most important part of RadPrimer. Our experts are leading world experts, our subject matter experts that work on the content are leading experts in the world, and they take a lot of pride in keeping the content current. And that is also because they actually use the system quite a bit. So with that, I'm going to go into the curriculum. So when you log on, this is the screen that you will see. On the top, there are 4 tabs: curriculum, assignment, activity, and performance. Curriculum is where all the reading lessons and the topics are organized by rotations. Assignments RadPrimer can come as an individual subscription, or if your institution signs up for it, it actually combines with the faculty module. So if your faculty, if you have this with your institution, the faculty can assign reading topics and tests, and that will come under the assignments tab. The activity lets you view your activity in terms of quizzes and also lets you do comprehensive quizzes. And finally, in the performance, it helps you monitor your performance by topic. On the right, there are 3 buttons. One is for just any messages that you're receiving from customer support. And there is also a profile section where you can set your year of residency, and that helps when you're getting compared your performance with all the global. And I'll come back to that later. On the left, there is a bookmark field, and I will also show you how to do the bookmark. So I just want to make sure that there's no, just going to go back and see if there's any questions. I'm going to end this poll now. Okay, so I'm just going to see if I can answer questions. RadPrimer is not free, but we are working closely with IRIA to see if we can give you, because you can actually just go to the website and purchase it, but those are US prices. We want to give you a good deal, so we are going to work with IRIA, and hopefully if there's enough of you that are interested, we can make it pretty attractive. So going back to RadPrimer, the demo, when I log in. So you can see that there are 2 levels of curriculum. They consist of 340 lessons that contain about 4,000 reading topics and over 5,000 questions. So what we suggest is all the first-year residents start out with the basic curriculum. You want to go through each reading lesson before each rotation, finish all the practice questions associated with that rotation, and then at the end of the rotation, you take the questions again. And that way you can measure your learning. And as you, once you master the basics, probably at the end of the first year or maybe a little bit longer, because I think in India, the residency program is 3 years, then you move on to your intermediate. If you can see that in the basic, there are about 2,200 questions that are available to you. And if I go into intermediate, the number of questions associated with that curriculum changes to about 3,600. So just to go inside, I'm going to get into the musculoskeletal topic. The musculoskeletal lesson has two. I'm just going to randomly pick the non-traumatic diseases, orthopedic implants. So again, just how this is laid out, the lessons are on the left. All of them have a standard template, and that actually is very important because that forces our authors who are world experts to keep things extremely simple and standardized. So a lot of the lessons are bulleted, and what a lot of people find advantageous is that you can very quickly, it saves you time in not having to refer to multiple books. You just take this and very simply you can get all the key things that you need. The focus really is on your foundations. So whereas StatDX is for practicing radiologists and it has a lot of subtleties, Rad Primer tends to be it just focuses on your foundations. So the lessons are on the left. The middle pane has practice quizzes. So now you see that I've entered the non-traumatic diseases lesson topic, and there are 16 questions. So it allows you to test yourself based on the lessons that you choose. So if I want to maybe go into the musculoskeletal, which is a higher level up, I have 145 questions. So we are trying to really make it, customize it for you as whatever you're feeling comfortable with, you can test yourself on that. The right side is an activity overview that allows you to at a glance see how much you've done. So if I go into orthopedic implants, I've talked about the learning objectives. As you can see below, these are the lesson topics. If I go into a lesson, so this is how a lesson is organized. On the left side is the reading material, and all of them are coupled with images. On the top left, if you see this blue table of contents, I can click this. And again, all the lessons have the standard table of contents. So start out with key facts that I can very easily move into the definitions, terminology. When I can go on to pathology and just keep reviewing it. Towards the end, there are references. So if I want to find out more, if I'm interested in from a research perspective, or if I'm confused, I can easily click and this will take me to the source material. The author's name is also always written at the top. So I can click this and it'll give me an overview of who the author is. So just going to the images, you can see that there is a pane, image pane. So I can just keep hitting right and it'll keep changing. Within the images, there are two tabs. One is a text box, that is the image caption. So once I've done my reading and I want to focus on the images, I can again keep going here. It'll keep updating the image caption. If I want to see the images, because it's all about images in radiology, I can click the magnifying glass and I can get a much more high resolution image to view. So I'll just stop right here and see if there's any questions. So somebody's asking if we can have lunch now. And I think the idea for this session is that you could have lunch while I'm doing this. So I think if you do want to get lunch, please feel free. I'm going to continue with my session. So another question I've seen is it's same like Radiopedia. So this is very different from Radiopedia. Radiopedia, I think, is you can compare Radiopedia to StatDX because they're both decision support systems where you can find out more information. Rad Primer is for students. It's a training curriculum. And Radiopedia, again, I can talk about why we feel that StatDX is better than Radiopedia, but this session is more on Rad Primer, so I'm going to just not get into that. Okay, so now just going back here. Just going to go into my lesson. What I want to show you is that once you've reviewed the lesson, you can go here and hit completed. And now when I go back to my main sessions, I'll see that the lesson that I was just reading has been marked crossed and it says that it's been read. So it makes it very easy for you. If you have to now go back to do something else, you can come back and you know where to start from. Very quickly, I want to talk about how to bookmark something. So if I'm interested in the implants, or if I want to come back to it, there is a tab right here. I press this, it gets turned in orange. And if I go back to my home screen, and if I go to bookmarks, you can see that it comes here. So that's another easy way for you to get back into something that you need to go back to. Okay, so I'm going to go back into musculoskeletal, and I'm going to show you how to take practice quizzes. So say I've finished reading orthopedic implants, and I want to test myself on the 16 questions. I go to this middle pane and I create a quiz for myself. So I can take it for all 16 questions, or I can limit it. And for the sake of this demo, I'm going to limit it to 3 because we have limited time. Of the questions, I can there's 2 types that I can either take it in tutored mode or testing mode. I'm going to show you how to do tutored mode. Testing mode basically is you get questions one after the other. You don't find out what the right answer is, and at the end of the quiz, you'll get your result. So that's a good thing to do once you're just testing yourself. But if you're practicing these quizzes after having read it and you want to get more information, tutored is a better way to go. There are 2 types of question styles. There's case-based and traditional questions. I'm not going to distinguish between the 2, and I'm going to create this quiz now. So I want to make this a little interactive, so I'm going to try and use the poll questions so you can help me answer what you think is right. I'm going to just read the question, and then I'll create this poll. So this question is, what is the best description of the total hip prosthesis? And there's 2 images. The options are acetabular small particle disease, periprosthetic fracture, anterior dislocation, or adverse localized tissue response. So I'm just going to show you this, if you can see the image, and then I'll show you the second one. And while you're thinking of the answer, I'm just going to go back and quickly create the poll. Reset the poll. I don't know how to do that. Add a new poll. Okay.
Murli sir.
So I'm going to publish. So if people can answer what they think is the right answer, I'll just give 30 seconds. Again, which is the best description of the total hip prosthesis? Acetabular small particle disease, periprosthetic fracture, anterior dislocation, or adverse localized tissue response.
Oh my God.
So everyone, it's the winner is C. So I'm going to poll, and I'm going to try for C now. If I press C, as soon as I press the answer, you can see that I get the peer average. So this is showing that 96% of the people who attempted it got it right. So that gives me an idea that this is a relatively easy question. At the same time, if I had gotten it wrong, sometimes there's teaching points within that explain to you why it's wrong. And you can also read a little bit more information at the bottom. So great, I'm going to move on to the next one. So here as well, again, all the authors' names are always listed, and if I click them, you can find out a little bit about them. The question here is, which is the best description of the fracture fixation on these immediate post-operative radiographs? I'll show the images and then I'll read the options. So the options are unacceptable valgus angulation, acceptable valgus angulation, fractured fixation plate, or malrotation. So I want to go and just reset the poll, start the poll. No, that's not the wrong one. This one. Okay, so if you could help with the answers, I think from whoever, I see that B is the most popular, so I'm going to go with B. So if I click on B, that is wrong. And you can see that 61% of the peers got it right. So it's a difficult question. So I'm going to just randomly go with A, and A is the right answer. So you can see as soon as I select the right answer, there's a teaching point, and it also allows me to go into the related reading. So again, the point here is that it makes it very simple and easy and quick. I guess the time efficient for you to get answers, learn as you go along. So I can click this, read it, and then there's another link that helps me to come back here. I'm also able to flag questions. So you can see this button. If I flag it, if I find it challenging, I want to come back to it, then I simply flag it, and then I can retake this question. It goes back into the question pool. My last question. Patient history, this is a case-based question. 67-year-old male patient with a painful total knee prosthesis. What is the most likely diagnosis? And I'll show the images. And the options are prosthesis loosening, metastatic disease or other lytic tumor, arthroplasty particle disease, infected prosthesis, or stress shielding. So I'm just going to go back. I think I'll have to end this poll. Reset the poll. Okay. So I'm going to preview. I'm going to publish this. It's got 5 options. So it's between B and D. I think maybe B. So I'm going to go with B. So if I hit B. So again, this is very interesting because this is a reasonable alternative, but it's not the right answer according to RAD Primer. And you can see that this is it's a hard question. Only 53% got right. So if you get something that's close enough, it'll tell you that why it is a reasonable alternative, but not the right answer. I am going to then pick, I think I'll pick D. That's the next one. And that is incorrect. Why it's incorrect is here. I'm just going to go randomly now and pick the remaining. So the right answer is C. And gives you details about why it's right, gives you a teaching point, and it allows you to just, if I click this, it'll take me to the reading, and then I can come back to it. So finishing my quiz, it tells me how I did, and I can review the quiz, or I can go back into my reading material. Just coming back here, on the right side gives me an activity overview that allows me to understand how many topics I've completed and how many questions I've taken. So I'm done with the curriculum. If there's any questions, otherwise I'll move on to assignments. I'm going to end this poll. Going to chat. Okay. So the question actually, I don't know, to the organizers, let us know what time will this photo session restart. So Dr. Murli will have to answer that. But I think for me, I have another 5-10 minutes left, and then I'll be done. So Dr. Piyush, I will be done in 10 minutes. I'm almost done with the demo. Moving on to assignments, if your faculty, if your RAD Primer module is tiled to a faculty, this is where the faculty will put tests and reading materials. So I'm just going to skip over this since we have limited time. I wanted to show you the activity. Here is where you can keep track of all the quizzes that you've done. So things that are in progress you haven't finished, or the ones that are completed. So what I want to show you is this is the quiz that we just completed. So I can retake all the questions that I missed. And the interesting part here is that if I retake the missed questions, the answers get shuffled. So it's not like, the right answer is always number 3. It gets mixed so that you don't get used to just remembering that this was the right answer over here. Very powerful feature of Rad Primer is our comprehensive practice engine. So here, all the questions are available. So a lot of the times when residents are preparing for their tests or exams, they'll just take this entire thing in one go. Or what you can do is say, I'm a first-year resident and I've completed 5 rotations. I will eliminate all the intermediate and I will go to basic, and maybe I will just select on the 5 rotations I have completed, and that will filter the questions accordingly, and then I can go and take those questions and test myself. I can filter them in other ways as well. I'm not going to get into the details, but it just allows you to really test yourself in different ways. Last slide for me, the last is the performance tab. Here I can see for all the lessons, both intermediate and basic, it allows me to see how many lessons I've completed, how much reading time I've spent, how many assessment questions I've taken, my score overall for each of them. And then this is a really important field where it allows me to compare myself with all the other Rad Primer users globally. So this is basically a good way to assess your performance. And sometimes you feel that you find that you are, missing in only a few of the topics, and then you can just go and brush your knowledge on those. I think that's all I had. If there's any questions, please feel free to ask me. Looking at the responses here, I think trial for StatDX. So the StatDX, I'm going to work with Dr. Amarnath and see if we can do that. But if you are interested in the Rad Primer trial, please connect with Dr. Murali, and he will connect with me, and we will be giving you a free 1-month trial so that you can use it yourself and see how you feel. And if a lot of people are interested, we can come up with a pretty attractive pricing. Thank you for your time. Before I end, I wanted to also give you my email if anyone's interested in getting in touch with me directly. And I had also mentioned our healthcare hub, where there's a lot of very important information on the COVID crisis. So you can also go there. So that's it from me. Dr. Murali. I'm going to stop sharing. Dr. Vijay, if you're there, are you? Yeah. Hi, Dr. Vijay.
I'm here, yeah.
Yeah, we can hear you. So you can now start. I think everybody's been missing your session that was going on.
I will do it.
Yeah.
Thank you.
Thank you.
Murali sir? Murali sir?
Dr. Vijay, I don't know where Dr. Murali is. Should I try calling him?
No, but is he?
Let me just call him.
I'm proceeding. Yeah. Thank you. So I'm sorry for whatever technical. Sorry for whatever the technical thing happened. Really apologize. I literally continued everything, but anyway, I'll redo it again. So Murali wanted me to start from 13th slide. So this is the typical picture of a foreign body impacted in the right main bronchus. Then there is occlusion of the right main bronchus. There is hyperinflation because of ball valve mechanism, what I have what I probably must have heard from me earlier, that the bronchus expands and elongates during inspiration, and it narrows and decreases in length during expiration. So whenever there is a foreign body impacted in the main bronchus, air goes in during inspiration, but it comes out during it does not come out during expiration because of this valval type of blockade of the bronchus by the foreign body, and air gets trapped in. That is known as obstructive hyperinflation, and that's a surgical emergency, and it has to come out. And because of the varying grades of severity, the bronchus can rupture, produce pneumatocyl, produce air streaks within the lung parenchyma, surgical emphysema, pneumodiastema. So that's a typical what you call foreign body impaction, and the diagnosis is obstructive hyperinflation. Obstructive hyperinflation because of impaction of the foreign body. And this is a virtual bronchoscopy showing the right main bronchus is occluded there. And this is the final diagnosis: foreign body impacted right main bronchus, obstructive hyperinflation, pneumodiastema, severe surgical emphysema. Now, this is a very typical case of non-visualized left lung parenchyma, shift of cardiac mediastinum to left side, non-visualized left main bronchus, non-visualized left pulmonary artery. So all of them put together will tell us that this is a agenesis of left lung. Agenesis of left lung. Very typical of agenesis of left lung, because there is no left main bronchus, there is no left pulmonary artery, only right pulmonary artery. Pulmonary artery is continuous right pulmonary artery. Agenesis of left lung. That is very typical of agenesis of left lung. How do you differentiate between hypoplasia of left lung or hypoplasia of upper lobe or lower lobe? Is the typical what we see in Scimitar syndrome. Now, this is a baby presented with recurrent episodes of lung infection, respiratory tract infection. You see a large opacity, density with multiple cystic and air-filled lucencies within this large opacity, bubbly lesion within the left lung, draining into left inferior pulmonary vein, and arterial supply from systemic artery from the aorta. Now, what is clinching here is to say intralobar sequestration means there is an inferior pulmonary vein. The drainage of the lesion through inferior pulmonary vein into left atrium. Differentiate it from extralobar sequestration, because extralobar sequestration, they usually drain into systemic veins like esophageal system, portal system, subclavian intermammary veins. And usually the extralobar pulmonary sequestration will have a systemic artery, but intralobar can also have systemic arteries. And that is typical of intralobar sequestration, where you have drainage through, the drainage is occurring through left inferior pulmonary vein. You can see here, this is the inferior pulmonary vein. This is the opacity, inferior pulmonary vein, draining into inferior pulmonary vein. And this is a systemic artery supplying the lesion there. Intralobar sequestration of left lung. How do you differentiate intra-extralobar? I have already told you that extralobar variety is common drain into esophageal system or into systemic veins. Intralobar variety typically drains into inferior pulmonary vein. There can be hybrid lesions also. Now, this is a typical pattern of a figure of 8 appearance or snowman's sign. Now, what is figure of 8 appearance? Figure of 8 appearance occurs in the anomalous stroke, anomalous pulmonary venous connection, where all the pulmonary veins drain into a left ascending vertical vein. This is left ascending vertical vein. That is the anomalous vein. All pulmonary veins don't go into left atrium. They drain into left ascending pulmonary vein. This drains into the nominate vein. That drains into SVC. So dilated left ascending vertical vein forms the one limb of 8, figure of 8, superior left limb. Then dilated right SVC forms the other dilated limb of the right upper limb of the figure of 8. So left vertical vein dilated, right SVC dilated, right heart border, left heart border together form a figure of 8 appearance or a snowman sign in a typical supracardiac total anomalous pulmonary venous connection. So figure of 8 sign or snowman sign is a typical picture of total anomalous pulmonary venous connection supracardiac. Why supracardiac? The ascending vertical vein, all the pulmonary veins are draining into ascending vertical vein. Now, cardiac means all the pulmonary veins drain into coronary sinus or directly into the right atrium or one of those cardiac structures. Then infracardiac or infradiaphragmatic is if it drains into the portal venous system. So pulmonary venous connection could be partial or total. Total is cardiac, supracardiac, infracardiac. Now partial could be anywhere. Partial venous connection could be only left upper pulmonary vein can turn into nominate vein, or right lower pulmonary vein can turn into IVC, similar syndrome. So that is partial and upper pulmonary venous connection. Now this is a radiograph of mitral heart disease. Now how do you grade pulmonary venous hypertension? Grade 1 is capitalization of the pulmonary veins, pulmonary vessels. Capitalization. How do you say it's capitalization? Because you see the first interspace, first strip, second strip, first interspace. There will be more number of blood vessels in the first interspace when compared to the lower zones. Then it is known as pulmonary venous hypertension. Look at the first interspace between first and second strip anteriorly.
Please try.
More vessels. Murli sir, again gone. Murli sir. Shall I continue, sir? Murli sir.
Yes, sir. We can hear your voice, sir. You can continue, sir.
You can see my slides also, no?
Yeah, we can see your slides also, sir.
Thank you.
Yeah.
So this is pulmonary venous hypertension, and grading of pulmonary venous hypertension.
Yes,
one
sir.
first
We
grade.
can hear your voice, sir. You can continue, sir.
You can see my slides also, no?
Yeah, we can see your slides also, sir. Yeah.
So this is pulmonary venous hypertension, and grading of pulmonary venous hypertension.
Yes,
one
sir.
first
We
grade.
can hear your voice, sir. You can continue, sir.
You can see my slides also. So these are the pulmonary veins in the first interspace, not so dilated in the lower zones. And grade 1 pulmonary venous hypertension is capitalization of the pulmonary vessels. Grade 2 is curly lines, and grade 3 is pulmonary edema. This is pulmonary edema or bat swing appearance, that is perihilar opacities, bat swing appearance, pulmonary edema. Typical of pulmonary edema is bat swing appearance. What is reverse bat swing appearance? Nowadays we commonly see in COVID pneumonia. Reverse bat swing appearance is they are away from the hilum. They are peripherally located. They are not around the hilum, but they are peripheral. Reverse bat swing. Just remember a bat and reverse bat swing is they are along the pleural surface. Reverse bat swing. So reverse bat swing occurs in COVID-19 pneumonia. Very commonly nowadays, entire life is going around COVID pneumonia only. Chronic eosinophilic pneumonia and organized pneumonia are BOOP used to call earlier. Bronchial vessel carcinoma, pulmonary contusion, pulmonary hemorrhage infarction occurring peripherally, vasculitis and aspiration. That is reverse bat swing. Now, this patient presented with a typical history of right heart failure, pedal edema, ascites, and dizzy on exertion. A very typical feature of chronic constrictive pericarditis. Look at the thickening of pericardium here. More than 3 millimeters thickening, enhancement, pericardial fluid. You see pericardial fluid, diffusion restriction, thickening here. And then more importantly, on a cine stack study, you see that there is a septal bounce. Look at this paradoxical motion of the septum. The septum starts bouncing in systole and diastole because that occurs because of early diastolic filling. Early diastolic filling leads to septal bounce, and there's a restriction of movement also because of thickened pericardium. So the septal bounce with thickened pericardium, enhancement, and thick pericardial effusion, ascites, right heart failure, biatrial enlargement of both the atria are very, very typical of chronic constrictive pericarditis. Now, what is the other feature typical of constrictive pericarditis? Look at this chunky pericardial calcification. Chunky pericardial calcification is very typical of chronic constrictive pericarditis. So together, CT and MR are 100% accurate in deciding whether it is chronic constrictive pericarditis or not, with those typical features. Now, what is the differential diagnosis of chronic constrictive pericarditis? It's restrictive cardiomyopathy or endomyocarditis. But if you find that there is pericardial calcification, thickened pericardium, all of them, very biatrial enlargement is very typical of chronic constrictive pericarditis. Now, this lady with hemoptysis, you can see that there's a mass, partially calcified mass, central mass in the right hilar region, projecting into right main bronchus and involving the right upper lobe bronchus. The mass shows peripheral calcification and dense contrast enhancement. So, a dense contrast enhancing central bronchogenic mass with peripheral calcification and collapse, chronic collapse of the upper lobe parenchyma is very typical of a bronchial carcinoid or bronchial adenoma, what they used to call earlier. So remember, a central bronchogenic mass, dense enhancing, peripheral calcification, occluding the bronchus completely. This is central mass, not peripheral. Hyper enhancing, typical of a bronchial carcinoma or a bronchial adenoma. Now, this baby was found to have a mass antenatally. Postnatally, we did a CT scan, and you can see a large chunky mass involving the predominantly the septum and lateral walls. Septum and lateral walls. Septum anterior and lateral walls. Septum anterior and lateral walls. Chunky mass, anterior detected mass, very typical of a rhabdomyoma. There can be multiple masses. There can be multiple masses also. Rhabdomyoma. So rhabdomyoma, if you suspect antenatally, you always try to look at tuberous sclerosis complex. Look for multiple cardiac masses. And any infant or unit coming with an asymptomatic cardiac mass, not chunky mass, always suspect a rhabdomyoma. That is very typical, and especially tuberous sclerosis complex. And more so importantly, it involves the left ventricle, very common. So left ventricle wall, very common. Remember all these findings. Now, this is a spotter, literally swelling, chest pain, bubbly expansile cystic mass involving left chest wall with rib erosion. Now, in the lower cuts, you see that there is a lamellated type of membrane type of calcification in the liver. So this is typical of chronic hydatid, and this also is hydatid. So cystic lesion, expansile cystic lesion involving the ribs with peripheral axial calcification and fluid levels with a typical hydatid calcification there. If this were not to be there, hepatic calcification, you can suspect other conditions known as that phegnomoshic, that one mnemonic is there, phegnomoshic. So fibril dysplasia, eosinophilic granuloma, germ cell tumor, non-Hodgkin fibroma, metastasis, multiple myeloma, angiospermal bone cyst, solitary bone cyst, histiocytosis, and all those things. So that is a differential diagnosis. But here, because of this lesion, your clue, you suspect a hydatid cyst of the ribs. Now, this patient presented with PAH, presented with shortness of breath, and on CT, you see dilated pulmonary arteries, MPA more than 3.2, more than 2.8 is abnormal, more than 2.8 is abnormal, but it is 3.3. Or look at the diameter of the aorta and pulmonary artery. If the diameter of the pulmonary artery is more than that of the aorta, definitely dilated. Absolute is 2.8 or dilated when compared to that of the aorta. RPA dilated, MPA dilated, LPA dilated. There's an enhancing hypervascular eccentric mural thrombus in RPA. It's a chronic thrombus. Any chronic thrombus gets vascularized, enhances. It is fixed mural thrombus in RPA. Dilatation of right ventricle, right atrium. Straightening of intraventricular septum. All these features put together tell us that patient has PAH. Now, patient has chronic thrombus. So this is known as a chronic thromboembolic type of pulmonary artery hypertension because of previous organized thrombus in the pulmonary arteries. And nice classification. Whenever you diagnose pulmonary artery hypertension, you do nice classification. And a nice classification, type 4, chronic thromboembolic pattern of pulmonary artery hypertension, type 4. Remember, the signs are pulmonary artery dilated, chronic mural thrombus, dilated left right heart chamber, straightening of IVS, suggestive of right heart dysfunction. All these features put together tell us that it is a chronic PAH with chronic PTE type 4. Now this is literally this, if you see once, you don't forget it. All I have to tell you is patient worked in a coal mine that I have not given you in the history. Now this calcification, axial calcification of the hilar lymph nodes or mediastinal lymph nodes is very typical of silicosis. In addition to that, there are multiple small to varying size nodules, and most of the nodules show calcification. So this pattern of axial calcification of hilar or mediastinal lymph nodes and multiple calcified, non-calcified lung nodules going into fibrosis later on is very typical of silicosis. And always look at the pattern of calcification of the lymph nodes. That is eggshell calcification, very typical of silicosis. Look at this picture. Again, a symmetric, rather perihilar distribution of multiple ground glass nodules, reticular shadows, bronchiectasis, and pneumatoceles or vacuolation. So this typical picture in a given situation of recurrent fever, long-standing fever, cough, SOB, weight loss, and a fatty liver. Look at this on plain CT. On plain CT itself, there's a fatty liver. You can see the vessels, blood vessels. Hepatic veins should not be seen on a plain CT abdomen. If you see hepatic veins, that means there's severe fatty liver. So severe fatty liver is a common feature in retroviral disease. So retroviral disease, symmetric perihilar distribution, crazy paving pattern, nodules, reticular shadowing, pneumatoceles, bronchiectasis, very typical of pneumocystis carinei. Now we call pneumocystis jirovecii pneumonia. Very typical pattern, and this pattern can mimic coronavirus pattern nowadays. So any bloody opacities in the lungs, symmetric shadows, hilar, perihilar, lower zones, upper zones, symmetric, first corona, then others. That is what is happening nowadays. So that is typical. Now this is a baby, this child with failure to thrive, left heart enlargement, LV dysfunction. What is the abnormality? Look at the color coding. Pulmonary artery is red, LED is red. Pulmonary artery is here is green, light green, LED is light green. Aorta is dark green, circumference is dark green, RCA is dark green. For you here, you can see the LMCA and LCX. LED is not seen from aorta. RCA also seen from aorta. So LED is arising from pulmonary artery. This is known as anomalous origin of left coronary artery from pulmonary artery. This is a dangerous situation in infantile form. Baby will die if there are no collaterals. But if it is not very severe, then they survive into adulthood, develop multiple collaterals. But with the compromise of any function, recurrent myocardial infarctions, myocardial ischemia, so on and so forth. So this is an anomalous origin of left coronary artery from pulmonary artery. Now, this is a pre and post biopsy. I have mentioned here pre and post biopsy. Post biopsy pneumothorax. So post lung biopsy complications, pick the wrong statement. Now, this is the wrong statement. 5. What are the right statements? Needle entry must always be in the mid intercostal space. Never go into superior or inferior, because you've got intercostal arteries there and you tend to produce massive pleural effusion, hemorrhagic pleural effusion. Then pneumothorax is most frequent complication. Yes, 8 to 60% pneumothorax. Hemoptysis occurs in incidence 10%. Yes, hemoptysis can occur in 10%. Small bore catheter range of pneumothorax is mostly supplement. Exactly. In this pneumothorax, we can just put an intracath of 18 or 20, take out the needle with the only plastic sheet, start aspirating the pneumothorax. Patients get benefited very often, very soon. No need for intubation, no need for ICD placement. Now, what is important you have to do is position of the patient for 30 minutes on the opposite side. No, you have to position the patient on the same side as the puncture, because causing compression and you are causing the opposition of the pleural surfaces and lung parenchyma together, so that the air get the sealing of the puncture, and also escape of air is lessened, less quantity of air is escaped through the puncture. So this is the wrong answer. You have to put the patient on the same side, not on the opposite side. Rest all are right in this case. This is a typical picture of multiple peribronchovascular distributed nodules. Typical picture of low-grade fever, dry cough, multiple peribronchovascular distributed nodules, sarcoidosis. And this is known as a computer-aided detection of multiple nodules. We don't use anymore now. Probably when AI comes, which can be artificial intelligence can take over this. Multiple nodules, typical nodules, peri-lymphovascular distribution of the nodules, very typical of sarcoidosis. This can also occur in other two conditions like lymphangitis carcinomatosa and number 3, metastasis lymphangitis carcinomatosa, or again typical pattern. Now, this is a classic pattern of sarcoidosis with you find that there is bilateral hilar lymph node enlargement, bilateral symmetric hilar lymph node enlargement, in addition to the nodules. In addition to the nodules mentioned above, are very typical of sarcoidosis. Then Now comes the actual picture. Patient onset fever, body pains, loss of taste, loss of smell. Very typical distribution: peripheral, ground glass, nodules, consolidations, and septal thickening. 4x5. That is, this is a typical picture of coronavirus, COVID-19 pneumonia. Multiple peripheral, ground glass nodules, consolidations, and septal thickening. If severe, there can be air bronchogram and evacuation. If the patient is resolving, there can be predominantly septal thickening and some interlobular thickening, septal thickening, and some early fibrosis. So, but this pattern nowadays, with this history, is very typical of coronavirus, that is CORAX5. Now, this is a case of mitral stenosis with recurrent hemoptysis, and what you see is multiple nodules, multiple hemocytes, multiple small calcific nodules that occur because in chronic mitral stenosis, there is pulmonary venous hypertension, recurrent hemoptysis because of increased pulmonary capillary bed pressure, there is rupture of the pulmonary capillaries, hemoptysis, hemocytin deposition. This hemocytin deposition, long-standing, will cause ossification, and that produces what is known as pulmonary ossific nodules, typical of mitral stenosis, chronic mitral stenosis. And these are nodules. See, these are nodules. These are small, multiple pulmonary ossific nodules that occur in chronic PVH due to mitral stenosis. Now, recurrent cough and wheeze. Wheeze means patient has some airway disease, small airway or large airway, and recurrent cough, infection or recurrent infection. And on X-ray, you see these tubular shadows, tubular densities on X-ray. Glove finger sign. What is glove finger sign? Glove finger sign is typical fluid distended, gloved finger sign, typical fluid distended dilated bronchi opacities. These are air distended, these are fluid distended. So recurrent wheeze with these gloved finger sign of multiple tubular cylindrical densities within the both lung fields are typical of ABPA, allergic bronchopulmonary aspergillosis, colonizing the dilated bronchi, causing infection, recurrent infection, dilatation, bronchiectasis, reinfection, fluid distension. All these causes this gloved finger sign or tubular density. Now, this is a surgical emergency, trauma. You see here fracture of the left clavicle, surgical emphysema, endotracheal tube, right pneumothorax. This is tension pneumothorax. There is eversion of left dome of diaphragm. Left dome of diaphragm is completely everted, completely opposite side into the diaphragm. Because of ET tube, we don't have shift of mediastinum. Otherwise, there was a large shift of mediastinum. Severe collapse of left lung. Typical picture of tension pneumothorax. Remember, tension pneumothorax is a surgical emergency, and you have to inform the clinician immediately. Now, what is dominance? Now, whenever you report a coronary artery angiogram, you always call right dominant or left dominant or co-dominant. Now, what is dominance? Majority are right dominant. That is, from RCA, you get PDA and PLBB. Now, some are left dominant, but 30%. That is, from circumflex will give rise to PDA or PLBA. And 10% are co-dominant. What are co-dominant? From RCA, you get PDA. From circumflex, you get PLBB. These are a co-dominant system. Nothing different, nothing major, but just because this is a pattern, this is a nomenclature. So remember, right, left, and co-dominant. This is a co-dominant system because circumflex giving rise to PLBB and RCA giving rise to PD. Co-dominant system. Now, this is a CT coronary angiogram showing a plaque in midlety. What is the morphology of the plaque? The plaque is this known as napkin ring sign. This is the vessel. This is a fatty halo inside. That is a fibrotic rim outside. So, and a chunky microcalcification. So, microcalcification, fatty halo, and peripheral fibrocalcific core are very typical of a vulnerable plaque. What is a vulnerable plaque? Vulnerable plaque is the one which ruptures very fast and can produce massive acute myocardial infarction, which can be life-threatening. So, if you see a vulnerable plaque, you have to inform the cardiologist that I am looking at a vulnerable plaque, and you have to be very careful and put the patient on aggressive statins. And the sign is napkin ring sign. Napkin ring sign. Now, surgical emergency again. Patient on ET tube. NG tube has gone into the left lower lobe bronchus, and whatever fluids are given are opacifying the collapse, severe collapse of the left lung. There is no mediastinal shift. ET tube is there. That's why there is no mediastinal shift, and wrong placement, misplaced NG tube, even ET tube is going into right main bronchus. It is not there at the carina, it's going into right main bronchus. So both ET tube and NG tube are misplaced. Surgically, it's an emergency, immediately inform your emergency physician. Now this patient presented with a typical history of cough, rusty colored pool and sputum. Rusty colored pool and sputum always says that there's a chronic cavity, chronic pus with some secondary infection. Now, secondary infection is because of fungus producing rusty sputum. Now, this rusty sputum can also be produced by gram-negative organisms like Staphylococcus, gram-negative organisms like Klebsiella, and also Staphylococcus. So, Klebsiella, fungus, and Staphylococcus can produce a rusty sputum, and this in the existing cavity, tuberculous cavity, there's a nodule within the cavity, and there's a crescent sign. All are typical of a secondary infection of a tuberculous cavity with Aspergillus, and diagnosis TB cavity with aspergilloma. Very typical. Patient presented with weight loss 3 months, fever, PUO, multiple miliary mottling, multiple nodules, miliary mottling, small non-enhancing densities in spleen, granulomas, lymph nodes. So miliary tuberculosis involving both lungs, multiple miliary mottling, multiple tiny miliary nodules, lymphadenopathy, and spleen granulomas, miliary tuberculosis. Now this is very typical bronchogenic carcinoma in the right lung, invading the chest wall. There are multiple metastases in the chest wall, but what is important here is these multiple nodules in the myocardium, heart. So there is a right lung malignancy with cardiac metastasis. The importance of this slide is to identify what are the causes of cardiac metastasis. And lung cancer is one of the most common cause of lung cancer. Causes 38% of cardiac metastasis, 38% are caused by lung cancer. Then breast cancer, then lymphoma, leukemia, 16%. Then comes the other group of entities like melanoma, mesothelioma, mediastinal malignancies like teratoma, thymoma, lymphoma, renal cell carcinoma, pancreatic carcinoma, ovarian and gastric carcinoma. But remember, commonest cause for cardiac metastasis is lung cancer, and you can see both of them in the same picture. Now, this is a patient presented with sudden chest pain. Smoker, COPD, multiple small bullae, giving a reticular shadowing, obliteration of right CT angle, there is right pleural effusion, left dome of diaphragm is depressed, and there is a lucency with devoid of vascular markings along the left lower zone laterally and inferiorly. Pneumothorax. This is a spontaneous pneumothorax, lock-pilated spontaneous pneumothorax occurring, not lock-pilated exactly, it's also going up. You can see the pleural line, pneumothorax occurring because of spontaneous rupture of an emphysematous bulla, especially in chronic smokers with COPD. The bulla can rupture spontaneously, produce spontaneous pneumothorax, and they present with very typical chest pain. They present with typical chest pain, and in a chronic smoker with chest pain, to suspect pneumothorax, spontaneous pneumothorax, and they can be a surgical emergency or medical emergency also occasionally when pneumothorax is very severe. Now, 9-year male, viral fever, coronary artery aneurysm, very typical of a Kawasaki disease. Kawasaki disease is a viral disease with affinity towards the vessels, especially the coronary vessels, causes inflammatory vasculitis and aneurysms. Chronic disease causes aneurysm. So young children with history of viral fever before and now presenting with aneurysms are typical Kawasaki disease, and that is aneurysm in the Kawasaki disease. Typical Kawasaki disease. Now you remember one more point, that nowadays in coronavirus infection, in children, coronavirus infection is supposed to be presenting like a Kawasaki infection. We don't know what happens after 1 year, but coronavirus infection is presenting like a Kawasaki disease in children. Remember that point, very important. Now, calcified aneurysm, LV aneurysm occurs mainly because of usually and very commonly because of chronic infarct. Chronic infarct causing severe reduction, scarring, severe reduction in myocardial thickness, and aneurysm. True aneurysm, scarring, true aneurysm, LV aneurysm. Now, this is a case of scoliosis occurring, and what are these multiple nodules? See these multiple nodules in soft tissues, 1, 2, 3, 4. Look at here, multiple nodules. Look at these multiple nodules. All multiple nodules are also seen overlaying the lung fields. So scoliosis is a typical feature of neurofibromatosis because of associated vertebral anomalies. Now, these are multiple nodules in the soft tissue, and multiple nodules are overlaying the hemithorax as if giving a picture of metastasis. So this is a neurofibromatosis. So remember that you have got a very typical soft tissue nodules overlaying, giving a pseudo metastasis pattern. So always remember soft tissue bone leakage also are important when you are trying to report a chest radiograph. I think that's the end of the show. Sorry for the inconvenience.
Thank you so much, Vijay sir. You have done your presentation twice, I think.
One for myself, one for others.
So, thank you so much. It was a wonderful session. All of the residents who had joined were actually worried that you went offline. They were so eager to listen to your answers. So, thank you so much, sir.
Welcome, sir. Pleasure.
Thank you. So, all those who have joined us, we'll be closing the session now. And again, starting immediately another 10 minutes. So,
10 minutes, sir. Lunch break.
Only 10 minutes, sir.
10 minutes அப்படியே சாப்பிட முடியும்.
நீங்க அப்படியே லைவா பார்த்துட்டு சாப்பிடலாம் சார்.
சரி, அது என்னோட क्वेश्चन மட்டும் இருந்தா எப்படி அனுப்ப முடியுமா? கிடையாதா? அந்த இது chat பண்றதுக்கு வேற இருக்கா? எனக்கு
no specific questions sir. Otherwise I would have told you. Yeah.
ஓகே. ஒரு 1/2 hour இருக்குங்க சாப்பிடுறோம்னா.
சார் பார்த்துட்டே சாப்பிடுங்க சார்.
அவ்வளவு டைட்டா உட்கார்ந்து சண்டையில ஐயோ
பசங்க எக்ஸாம் எழுதுறாங்க. Therefore them it is required no.
சரி ஓகே
because other speakers also are busy, so we cannot waste time.
Okay.
So 2 o'clock we'll start next session, and then because if we start at 2 itself it will be 5:30 by we finish, so it's a marathon day. So we are starting at 2, sir. Please log out and log in again because we will be closing this session now. Yeah. Thank you so much. See you post lunch. 2 o'clock sharp.